Hello friends, Dr. Anil Ganju from New Delhi. Friends, my Delhi is a wonderful mixture of art, culture, history, heritage, architecture, culinary delights, and add to that the wonderful infrastructure we have here, the world-class conference facilities that are coming up in the form of world-class convention center. I'm delighted to inform you all that Delhi IADVL is bidding for Dermacon International 2023. We want all of you to be with us and host you and give you the best of academics, the best of heritage, the best of history, architecture and culinary delights. We would love to have you in 2023. So go ahead and vote for Delhi as the venue for Dermacon International 2023. See you in Delhi.
Hi, my name is Dr. Sanjeev Kandhari. I'm a consultant dermatologist from New Delhi. Delhi, as you know, is going to bid for Dermacon 2023 International. As a senior member of the fraternity, I'm going to vote for Delhi. I'm going to stand for Delhi, and I'm sure you'll all stand with me.
Hello friends, Dr. Anil Ganju from New Delhi. Friends, my Delhi is a wonderful mixture of art, culture, history, heritage, architecture, culinary delights, and add to that the wonderful infrastructure we have here, the world-class conference facilities that are coming up in the form of world-class convention center. I'm delighted to inform you all that Delhi IADVL is bidding for Dermacon International 2023. We want all of you to be with us and host you and give you the best of academics, the best of heritage, the best of history, architecture and culinary delights. We would love to have you in 2023. So go ahead and vote for Delhi as the venue for Dermacon International 2023. See you in Delhi. Hello friends, Dr. Anil Ganju from New Delhi. Friends, my Delhi is a wonderful mixture of art, culture, history, heritage, architecture, culinary delights, and add to that the wonderful infrastructure we have here, the world-class conference facilities that are coming up in the form of world-class convention center. I'm delighted to inform you all that Delhi IADVL is bidding for Dermacon International 2023. We want all of you to be with us and host you and give you the best of academics, the best of heritage, the best of history, architecture and culinary delights. We would love to have you in 2023. So go ahead and vote for Delhi as the venue for Dermacon International 2023. See you in Delhi. Hello friends, Dr. Anil Ganju from New Delhi. Friends, my Delhi is a wonderful mixture of art, culture, history, heritage, architecture, culinary delights, and add to that the wonderful infrastructure we have here, the world-class conference facilities that are coming up in the form of world-class convention center. I'm delighted to inform you all that Delhi IADVL is bidding for Dermacon International 2023. We want all of you to be with us and host you and give you the best of academics, the best of heritage, the best of history, architecture and culinary delights. We would love to have you in 2023. So go ahead and vote for Delhi as the venue for Dermacon International 2023. See you in Delhi. Hello friends, Dr. Anil Ganju from New Delhi. Friends, my Delhi is a wonderful mixture of art, culture, history, heritage, architecture, culinary delights, and add to that the wonderful infrastructure we have here, the world-class conference facilities that are coming up in the form of world-class convention center. I'm delighted to inform you all that Delhi IADVL is bidding for Dermacon International 2023. We want all of you to be with us and host you and give you the best of academics, the best of heritage, the best of history, architecture and culinary delights. We would love to have you in 2023. So go ahead and vote for Delhi as the venue for Dermacon International 2023. See you in Delhi. Hello friends, Dr. Anil Ganju from New Delhi. Friends, my Delhi is a wonderful mixture of art, culture, history, heritage, architecture, culinary delights, and add to that the wonderful infrastructure we have here, the world-class conference facilities that are coming up in the form of world-class convention center. I'm delighted to inform you all that Delhi IADVL is bidding for Dermacon International 2023. We want all of you to be with us and host you and give you the best of academics, the best of heritage, the best of history, architecture and culinary delights. We would love to have you in 2023. So go ahead and vote for Delhi as the venue for Dermacon International 2023. See you in Delhi. Hello friends, Dr. Anil Ganju from New Delhi. Friends, my Delhi is a wonderful mixture of art, culture, history, heritage, architecture, culinary delights, and add to that the wonderful infrastructure we have here, the world-class conference facilities that are coming up in the form of world-class convention center. I'm delighted to inform you all that Delhi IADVL is bidding for Dermacon International 2023. We want all of you to be with us and host you and give you the best of academics, the best of heritage, the best of history, architecture and culinary delights. We would love to have you in 2023. So go ahead and vote for Delhi as the venue for Dermacon International 2023. See you in Delhi. Hello friends, Dr. Anil Ganju from New Delhi. Friends, my Delhi is a wonderful mixture of art, culture, history, heritage, architecture, culinary delights, and add to that the wonderful infrastructure we have here, the world-class conference facilities that are coming up in the form of world-class convention center. I'm delighted to inform you all that Delhi IADVL is bidding for Dermacon International 2023. We want all of you to be with us and host you and give you the best of academics, the best of heritage, the best of history, architecture and culinary delights. We would love to have you in 2023. So go ahead and vote for Delhi as the venue for Dermacon International 2023. See you in Delhi. Hello friends, Dr. Anil Ganju from New Delhi. Friends, my Delhi is a wonderful mixture of art, culture, history, heritage, architecture, culinary delights, and add to that the wonderful infrastructure we have here, the world-class conference facilities that are coming up in the form of world-class convention center. I'm delighted to inform you all that Delhi IADVL is bidding for Dermacon International 2023. We want all of you to be with us and host you and give you the best of academics, the best of heritage, the best of history, architecture and culinary delights. We would love to have you in 2023. So go ahead and vote for Delhi as the venue for Dermacon International 2023. See you in Delhi. Hello friends, Dr. Anil Ganju from New Delhi. Friends, my Delhi is a wonderful mixture of art, culture, history, heritage, architecture, culinary delights, and add to that the wonderful infrastructure we have here, the world-class conference facilities that are coming up in the form of world-class convention center. I'm delighted to inform you all that Delhi IADVL is bidding for Dermacon International 2023. We want all of you to be with us and host you and give you the best of academics, the best of heritage, the best of history, architecture and culinary delights. We would love to have you in 2023. So go ahead and vote for Delhi as the venue for Dermacon International 2023. See you in Delhi. Hello friends, Dr. Anil Ganju from New Delhi. Friends, my Delhi is a wonderful mixture of art, culture, history, heritage, architecture, culinary delights, and add to that the wonderful infrastructure we have here, the world-class conference facilities that are coming up in the form of world-class convention center. I'm delighted to inform you all that Delhi IADVL is bidding for Dermacon International 2023. We want all of you to be with us and host you and give you the best of academics, the best of heritage, the best of history, architecture and culinary delights. We would love to have you in 2023. So go ahead and vote for Delhi as the venue for Dermacon International 2023. See you in Delhi. Hello friends, Dr. Anil Ganju from New Delhi. Friends, my Delhi is a wonderful mixture of art, culture, history, heritage, architecture, culinary delights, and add to that the wonderful infrastructure we have here, the world-class conference facilities that are coming up in the form of world-class convention center. I'm delighted to inform you all that Delhi IADVL is bidding for Dermacon International 2023. We want all of you to be with us and host you and give you the best of academics, the best of heritage, the best of history, architecture and culinary delights. We would love to have you in 2023. So go ahead and vote for Delhi as the venue for Dermacon International 2023. See you in Delhi. Hello friends, Dr. Anil Ganju from New Delhi. Friends, my Delhi is a wonderful mixture of art, culture, history, heritage, architecture, culinary delights, and add to that the wonderful infrastructure we have here, the world-class conference facilities that are coming up in the form of world-class convention center. I'm delighted to inform you all that Delhi IADVL is bidding for Dermacon International 2023. We want all of you to be with us and host you and give you the best of academics, the best of heritage, the best of history, architecture and culinary delights. We would love to have you in 2023. So go ahead and vote for Delhi as the venue for Dermacon International 2023. See you in Delhi. Hello friends, Dr. Anil Ganju from New Delhi. Friends, my Delhi is a wonderful mixture of art, culture, history, heritage, architecture, culinary delights, and add to that the wonderful infrastructure we have here, the world-class conference facilities that are coming up in the form of world-class convention center. I'm delighted to inform you all that Delhi IADVL is bidding for Dermacon International 2023. We want all of you to be with us and host you and give you the best of academics, the best of heritage, the best of history, architecture and culinary delights. We would love to have you in 2023. So go ahead and vote for Delhi as the venue for Dermacon International 2023. See you in Delhi. Hello friends, Dr. Anil Ganju from New Delhi. Friends, my Delhi is a wonderful mixture of art, culture, history, heritage, architecture, culinary delights, and add to that the wonderful infrastructure we have here, the world-class conference facilities that are coming up in the form of world-class convention center. I'm delighted to inform you all that Delhi IADVL is bidding for Dermacon International 2023. We want all of you to be with us and host you and give you the best of academics, the best of heritage, the best of history, architecture and culinary delights. We would love to have you in 2023. So go ahead and vote for Delhi as the venue for Dermacon International 2023. See you in Delhi. Hello friends, Dr. Anil Ganju from New Delhi. Friends, my Delhi is a wonderful mixture of art, culture, history, heritage, architecture, culinary delights, and add to that the wonderful infrastructure we have here, the world-class conference facilities that are coming up in the form of world-class convention center. I'm delighted to inform you all that Delhi IADVL is bidding for Dermacon International 2023. We want all of you to be with us and host you and give you the best of academics, the best of heritage, the best of history, architecture and culinary delights. We would love to have you in 2023. So go ahead and vote for Delhi as the venue for Dermacon International 2023. See you in Delhi.
Hi, my name is Dr. Sanjeev Kanthari. I'm a consultant dermatologist from New Delhi. Delhi, as you know, is going to bid for Dermacon 2023 International. As a senior member of the fraternity, I'm going to vote for Delhi. I'm going to stand for Delhi, and I'm sure you'll all stand with me. Hi, my name is Dr. Sanjeev Kanthari. I'm a consultant dermatologist from New Delhi. Delhi, as you know, is going to bid for Dermacon 2023 International. As a senior member of the fraternity, I'm going to vote for Delhi. I'm going to stand for Delhi, and I'm sure you'll all stand with me. Hi, my name is Dr. Sanjeev Kanthari. I'm a consultant dermatologist from New Delhi. Delhi, as you know, is going to bid for Dermacon 2023 International. As a senior member of the fraternity, I'm going to vote for Delhi. I'm going to stand for Delhi, and I'm sure you'll all stand with me. Hi, my name is Dr. Sanjeev Kanthari. I'm a consultant dermatologist from New Delhi. Delhi, as you know, is going to bid for Dermacon 2023 International. As a senior member of the fraternity, I'm going to vote for Delhi. I'm going to stand for Delhi, and I'm sure you'll all stand with me. Hi, my name is Dr. Sanjeev Kanthari. I'm a consultant dermatologist from New Delhi. Delhi, as you know, is going to bid for Dermacon 2023 International. As a senior member of the fraternity, I'm going to vote for Delhi. I'm going to stand for Delhi, and I'm sure you'll all stand with me. Hi, my name is Dr. Sanjeev Kanthari. I'm a consultant dermatologist from New Delhi. Delhi, as you know, is going to bid for Dermacon 2023 International. As a senior member of the fraternity, I'm going to vote for Delhi. I'm going to stand for Delhi, and I'm sure you'll all stand with me. Hi, my name is Dr. Sanjeev Kanthari. I'm a consultant dermatologist from New Delhi. Delhi, as you know, is going to bid for Dermacon 2023 International. As a senior member of the fraternity, I'm going to vote for Delhi. I'm going to stand for Delhi, and I'm sure you'll all stand with me. Hi, my name is Dr. Sanjeev Kanthari. I'm a consultant dermatologist from New Delhi. Delhi, as you know, is going to bid for Dermacon 2023 International. As a senior member of the fraternity, I'm going to vote for Delhi. I'm going to stand for Delhi, and I'm sure you'll all stand with me. Hi, my name is Dr. Sanjeev Kanthari. I'm a consultant dermatologist from New Delhi. Delhi, as you know, is going to bid for Dermacon 2023 International. As a senior member of the fraternity, I'm going to vote for Delhi. I'm going to stand for Delhi, and I'm sure you'll all stand with me. Hi, my name is Dr. Sanjeev Kanthari. I'm a consultant dermatologist from New Delhi. Delhi, as you know, is going to bid for Dermacon 2023 International. As a senior member of the fraternity, I'm going to vote for Delhi. I'm going to stand for Delhi, and I'm sure you'll all stand with me. Hi, my name is Dr. Sanjeev Kanthari. I'm a consultant dermatologist from New Delhi. Delhi, as you know, is going to bid for Dermacon 2023 International. As a senior member of the fraternity, I'm going to vote for Delhi. I'm going to stand for Delhi, and I'm sure you'll all stand with me. Hi, my name is Dr. Sanjeev Kanthari. I'm a consultant dermatologist from New Delhi. Delhi, as you know, is going to bid for Dermacon 2023 International. As a senior member of the fraternity, I'm going to vote for Delhi. I'm going to stand for Delhi, and I'm sure you'll all stand with me. Hi, my name is Dr. Sanjeev Kanthari. I'm a consultant dermatologist from New Delhi. Delhi, as you know, is going to bid for Dermacon 2023 International. As a senior member of the fraternity, I'm going to vote for Delhi. I'm going to stand for Delhi, and I'm sure you'll all stand with me. Hi, my name is Dr. Sanjeev Kanthari. I'm a consultant dermatologist from New Delhi. Delhi, as you know, is going to bid for Dermacon 2023 International. As a senior member of the fraternity, I'm going to vote for Delhi. I'm going to stand for Delhi, and I'm sure you'll all stand with me. Hi, my name is Dr. Sanjeev Kanthari. I'm a consultant dermatologist from New Delhi. Delhi, as you know, is going to bid for Dermacon 2023 International. As a senior member of the fraternity, I'm going to vote for Delhi. I'm going to stand for Delhi, and I'm sure you'll all stand with me. Hi, my name is Dr. Sanjeev Kanthari. I'm a consultant dermatologist from New Delhi. Delhi, as you know, is going to bid for Dermacon 2023 International. As a senior member of the fraternity, I'm going to vote for Delhi. I'm going to stand for Delhi, and I'm sure you'll all stand with me. Hi, my name is Dr. Sanjeev Kanthari. I'm a consultant dermatologist from New Delhi. Delhi, as you know, is going to bid for Dermacon 2023 International. As a senior member of the fraternity, I'm going to vote for Delhi. I'm going to stand for Delhi, and I'm sure you'll all stand with me. Hi, my name is Dr. Sanjeev Kanthari. I'm a consultant dermatologist from New Delhi. Delhi, as you know, is going to bid for Dermacon 2023 International. As a senior member of the fraternity, I'm going to vote for Delhi. I'm going to stand for Delhi, and I'm sure you'll all stand with me. Hi, my name is Dr. Sanjeev Kanthari. I'm a consultant dermatologist from New Delhi. Delhi, as you know, is going to bid for Dermacon 2023 International. As a senior member of the fraternity, I'm going to vote for Delhi. I'm going to stand for Delhi, and I'm sure you'll all stand with me. Hi, my name is Dr. Sanjeev Kanthari. I'm a consultant dermatologist from New Delhi. Delhi, as you know, is going to bid for Dermacon 2023 International. As a senior member of the fraternity, I'm going to vote for Delhi. I'm going to stand for Delhi, and I'm sure you'll all stand with me. Hi, my name is Dr. Sanjeev Kanthari. I'm a consultant dermatologist from New Delhi. Delhi, as you know, is going to bid for Dermacon 2023 International. As a senior member of the fraternity, I'm going to vote for Delhi. I'm going to stand for Delhi, and I'm sure you'll all stand with me. Hi, my name is Dr. Sanjeev Kanthari. I'm a consultant dermatologist from New Delhi. Delhi, as you know, is going to bid for Dermacon 2023 International. As a senior member of the fraternity, I'm going to vote for Delhi. I'm going to stand for Delhi, and I'm sure you'll all stand with me. Hi.
Good evening to all who have logged in for this Vitiligo Day CME of the IADVL Delhi State Branch. I'm Dr. Gulhima Arora, Honorary Secretary, Delhi State Branch, and we welcome you all to this event with the theme, Celebrate the Beauty Within. Without much ado, I invite Dr. Sujay Khanpur, President, Delhi State Branch, to deliver the welcome address and begin the proceedings. Dr. Sujay.
Good evening, ladies and gentlemen. On behalf of IDVL Delhi State Branch, it gives me immense pleasure in welcoming you all to the World Vitiligo Day celebrations that we have organized under the theme Celebrating the Beauty Within. It's a day that truly needs to be commemorated because dermatologists and researchers all over the world for years have been striving hard to win the battle against this problem, which is not only cosmetically distressing and produces tremendous psychosocial impact, but also carries the stigma of leprosy, especially in this part of the world. There are several myths associated with this disease among patients that need to be addressed. Several meetings, webinars, CMEs have been organized throughout this week to celebrate the World Vitiligo Day. But I think our meeting is unique and very special for several reasons. First and foremost, we have the honor and privilege of having amidst us as our chief guest, the Honorable Minister of State for Labor and Employment, Independent Charge, Government of India, Shri Santosh Gangwar ji, whose life is truly inspirational for all of us and in the real sense reflects the theme of this meeting. Sir, we are extremely honored to have your gracious presence and welcome you to this meeting. It is also a great pleasure for all of us to have amidst us as our guest of honor, Dr. Hamzavi, a pioneer in the world of vitiligo, whose extensive and path-breaking work on this subject has always been a joy for us to read. This meeting is also special because it celebrates the creative talents of our young dermatologists by participation in a poster presentation session as a competition that was coordinated by the Delhi Residents Connect Committee, spearheaded by our secretary, Dr. Gulhima, along with the convener, Dr. Anuva Bansal, and its advisor, Dr. Prashansa Jaiswal, and the results of which would be declared shortly by our esteemed panel of judges of Dr. Gangwani and Dr. Vinay Singh. I would like to take this opportunity to welcome all the faculty members, chairpersons, moderators, panelists, who are all international experts in the field of vitiligo and who will share their vast experience with us in this evening. This meeting would not have been possible without the concerted efforts of our secretary, Dr. Gulhima, Dr. Rohit Batra, Dr. Sumit Gupta, Dr. Sandeep Arora, and I sincerely thank them for bringing this meeting together. I hope you will all enjoy the proceedings and deliberations this evening as much as we are enjoying bringing them to you. Have a great meeting. Thank you.
Government of India for having agreed to join us as our chief guest today. Despite coming from a conservative Indian background and suffering from a skin disorder which is shrouded with profound social stigma, he has reached a pinnacle in his political career, having surged ahead with determination. Listening to his story from him and using this perspective to better our professional careers is going to be enlightening. This will be followed by a live interaction by Dr. Over to you, Gangwar ji and Dr. Rohit Batra.
Thank you, Dr. Gulhima. गुड इवनिंग श्री संतोष गंगवार जी, आपका हमारे इस कार्यक्रम के अंदर स्वागत है। और श्री संतोष गंगवार जी केंद्रीय मंत्रिमंडल में श्रम एवं रोजगार मंत्री स्वतंत्र प्रभार हैं और जिस तरह हमारे प्रधानमंत्री नरेंद्र मोदी जी को विकास पुरुष कहा जाता है, संतोष गंगवार जी भी फेमस है इस नाम से, विकास पुरुष के नाम से। अपने करियर के अंदर इन्होंने बहुत ऐसे कार्य करे हैं, ना केवल बरेली और उत्तर प्रदेश के लिए बल्कि पूरे भारतवर्ष में। अटल बिहारी वाजपेयी जी के साथ भी मंत्रिमंडल में थे और इतने सालों से देश के लिए सेवा करते आए हैं। हम आप आईएडीविल संगठन जो है, जो भारत के चर्म रोग विशेषज्ञ हैं, हम आपके आभारी हैं कि आपने अपने अति व्यस्त दैनिक कार्यक्रम से हमारे लिए समय निकाला। और साथ ही डॉक्टर वीके चावला जी जो बहुत जिनका योगदान रहा कि आप हमारे समक्ष आज यहाँ हैं। मंत्री जी, आप कुछ कहना चाहेंगे समूचे भारत वर्ष के जो चर्म रोग विशेषज्ञ हैं उनके लिए? उसके बाद मैं आपसे कुछ प्रश्न करना चाहूंगा विटिलिगो के बारे में।
Indian Association of Dermatologists, Venereologists and Leprologists के प्रेसिडेंट डॉक्टर सुजय जी, ऑनरेरी सेक्रेटरी डॉक्टर गुलिमा अरोड़ा जी, और आप बोल रहे थे डॉक्टर रोहित बत्रा जी। इस लाइव वेबकास्ट में माध्यम से सभी जुड़े चिकित्सा क्षेत्र के सभी विशेषज्ञों का मेरा नमस्कार और मैं आप सबका स्वागत करता हूं। वास्तव में मैं अभी ये सोच रहा था कि इस सम्मेलन में ऐसा कितनी बार हुआ होगा जब इस समस्या से प्रभावित व्यक्ति को आपने मुख्य अतिथि बनाया है और आपने हमको यहाँ पर बुलाया है, और ये पहल आपकी संवेदनशीलता दर्शाता है और चिकित्सा में इसका बहुत महत्व होता है, ये हम समझते हैं। विशेषतः विटिलिगो के रोगी को उचित उपचार के साथ साथ मानसिक सहयोग की भी बहुत आवश्यकता होती है, ऐसा मैं महसूस करता हूं। मेरा जीवन का बड़ा हिस्सा विटिलिगो के साथ ही जुड़ा है। 1990 में से मुझे इसकी कैसे और 2-3 साल पहले से शुरुआत हुई, तो मैं उसके ज्यादा विस्तार में जाना नहीं चाहूंगा, पर मैं इतना जरूर कहना चाहूंगा कि मैंने बहुत इसका उपचार किया। अब मैं उसकी व्याख्या में भी नहीं जाऊंगा, पर मैंने ये महसूस किया कि सन 2000 में मैं कैलाश मानसरोवर यात्रा पर गया था। तब डायरेक्ट सनलाइट जो हमको मिली उससे हमारा कलर चेंज होने लगा और मुझे लगा कि जब 1 महीना मैं उस कैलाश मानसरोवर यात्रा में रहा तो काफी चेंज मुझको दिखाई दिया, पर मैं अब उस सबको भूल गया हूं। दुर्भाग्य से ये रोग हमारे समाज में एक भ्रांति है और कभी कभी इससे प्रभावित रोगियों को भेदभाव का सामना भी करना पड़ता है, और कभी कभी ऐसा होता है कि लोग देखने के बाद महसूस करते हैं कि इनसे हाथ भी मिलाया जाए या ना मिलाया जाए, और पीछे क्या बात करते हैं हम इसकी कल्पना ही नहीं कर सकते। और ऐसा मैंने महसूस किया है कि बिना परामर्श के लोग इसमें सलाह भी देते हैं और उपचार भी बताते हैं, और बहुत ही नुस्खे भी बहुत से लोग हमको दे भी गए, और लोग ये मानते हैं कि ये ऐसा रोग है जो बहुत ही भयानक है। ये मैंने अपने जीवन में 35 वर्षों में जो अनुभव किया है जो उसका नतीजा है। और इन परिस्थितियों में क्योंकि मैं ऐसा महसूस करता हूं कि शायद ये बीमारी केवल त्वचा के रंग की है, पर ये वास्तव में हमारे देश के अंदर ये मानसिक रोग भी बन गया है। बिना किसी पीड़ा के, शारीरिक पीड़ा के जीवन में समस्या उत्पन्न जो हो जाती है, इसके कारण रोगी कभी कभी अनावश्यक समस्याओं में आ जाता है और कभी कभी तो ऐसे कदम उठा लेते हैं कि जो हम जिसकी कल्पना नहीं कर सकते। और रोगी कैसे इससे मुक्त हो हम इसकी कल्पना ही कर सकते हैं। अक्सर लोग उम्मीद लगाकर किसी न किसी के कहने पर विभिन्न प्रकार के दवाओं को इस्तेमाल करते हैं, और इस कारण रोगी कभी कभी अपने स्वास्थ्य की भी चिंता नहीं करते हैं और स्वास्थ्य को नुकसान पहुंचाते हैं। और सही जानकारी के अभाव में केवल रोगियों नहीं, उनके परिजनों को भी समस्या पैदा हो जाती है। सही चिकित्सक वही है जो रोग के सही उपचार के साथ साथ रोगी को एक उचित सहायता करे और एक परामर्श उचित दे और संवेदनशीलता के साथ इन बातों को करने का काम करे। आप लोग बताते हैं ये रोग अलग अलग रोगियों में अलग अलग तरीके से गति और विस्तार रखता है। सबकी त्वचा में एक समान प्रभाव भी नहीं पड़ता है और उपचार कैसे हो यह भी समझ में नहीं आता है। ये जानकारी भी रोगी तक पहुंचाना जरूरी है कि हर रोगी के लिए सारे इलाज एक समान नहीं है। रोग के आधार पर आप दवा, क्रीम, अल्ट्रावायलेट रेज और कुछ रोगों में तो हमने इसमें देखा है कि लोग सर्जरी भी कराते हैं। मुझको बताया कि देश के बाहर लोग सर्जरी भी कराने की बात करते हैं, पर लगता यह है कि कोई भी इलाज कारगर इसमें साबित नहीं हुआ है। मुझे जानकर प्रसन्नता हो रही है कि आप लोग इस रोग के साथ गहन शोध में लगे हुए हैं और हम उम्मीद करते हैं कि इस रोग को मुक्त कराने के लिए आप प्रभावी चिकित्सा जल्द ही खोज लेंगे। मैंने अपने अनुभव से जो कुछ सीखा है, भले ही इस रोग का नियंत्रण न हो पर आवश्यकता यह है कि मानसिक जो क्षति होती है उस पर नियंत्रण की जरूर आवश्यकता है। और वास्तव में अगर आप मानसिक रूप से मजबूत हैं तो मुझे लगता है कि इस रोग का कोई अर्थ नहीं रहता है। और त्वचा का रंग पूरे विश्व में हम देखते हैं क्या है और कैसा है, पर हमारा मानना है कि त्वचा के रंग को लेकर इस बारे में भेदभाव नहीं करनी चाहिए। हम काले और गोरे का भेद एक अलग बात हम सब में को आता है, पर विटिलिगो के रोगियों के लिए अगर हम भेदभाव को मिटाना है तो एक तो मानसिक सोच बदलने का काम हमको करना पड़ेगा। तो मैं वैसे आपने मुझको यहाँ पर बुलाया था तो मुझे भी ये लगा कि आप हमें क्यों बुला रहे हैं, और हमने महसूस करा कि अब पूरे देश के अंदर हमारा चेहरा हमारी पहचान बन गया है। देश भर में जहां कहीं हम जाते हैं लोग हमको हमारे नाम से पहचान लेते हैं और हमसे बात करते हैं तो हमको अच्छा लगता है कि वास्तव में पूरे देश के अंदर, हम राजनीति में इतने समय से हैं, लोग हमको बात करते हैं और हमको पहचानने का भी काम करते हैं। तो वास्तव में हम इसको इस रूप में लेते हैं। पर मेरा आप सभी से आग्रह है कि अगर इसके जो मरीज हैं, क्योंकि मेरा मानना है कि लड़कियों के लिए इसमें बहुत तकलीफ होती है और ये डॉक्टर की जिम्मेदारी है कि डॉक्टर किस ढंग से इस बीमारी की चिंता करता है और इसका समाधान करता है। अगर आप मरीज के अंदर कॉन्फिडेंस बढ़ाने का काम नहीं कर पाए तो फिर चाहे कितना भी इलाज हो, मुझे लगता नहीं कोई उसका लाभ हो पाएगा। और लोग अक्सर इन बीमारियों को छिपाने का काम करते हैं और ऐसी कोशिश करते हैं कि किसी को पता न चले। तो मैं आप लोगों का आभारी हूं कि आपने मुझे यहाँ पर बुलाया और आपके माध्यम से इस क्षेत्र के सारे चिकित्सक साथियों ने मेरा परामर्श हो रहा है। मैं डॉक्टर चावला जी का भी धन्यवाद दूंगा कि डॉक्टर चावला जी हमारे परिचित है और उन्होंने हमको यहाँ पर बुलाने का जो आग्रह किया मुझे अच्छा भी लगा। पर इतना मैं जरूर कहूंगा कि आज आवश्यकता है कि इस शिकायत को हम, क्योंकि मैं इसे व्यक्तिगत रूप से इसे बीमारी कम मानता हूं, डीपिगमेंटेशन ज्यादा मानता हूं, क्योंकि वास्तव में इसका कोई रिएक्शन हमारी समझ में अभी तक नहीं आ रहा है कि इसका नुकसान क्या है, सिवाय इसके कि स्किन का कलर बदल जाए। पर काले और गोरे पूरे विश्व में हम सबको दिखाई देते हैं और डीपिगमेंटेशन अगर हम कायदे से समझा पाए, और ये डॉक्टरों की जिम्मेदारी ज्यादा है कि एक तो मानसिक रूप से अगर मरीज आ जाए, खासतौर से लड़की आ जाए, उसके अंदर कॉन्फिडेंस मेंटेन करने का काम आपको करना चाहिए। और हम इस रुचि में रहते हैं, अगर कोई हमको मिलता है तो हम इसी प्रकार का सुझाव देते हैं। तो मैं बहुत सारी बात कहने आपके बीच में आया हूँ नहीं आया हूं। मैं आपका बहुत बहुत आभारी रहूं, आपने मुझे अपने बीच में बुलाया। मेरी आपके लिए बहुत बहुत शुभकामनाएं। और मैं इतना ही कह सकता हूं कि आज तो चूंकि जो सिस्टम पूरे देश में चल रहा है, पूरे विश्व में चल रहा है, इसलिए हम सीधे आपसे डायरेक्ट सामने से बात नहीं कर पा रहे हैं। पर हमें इसमें भी अच्छा लगेगा कभी आप सारे प्रमुख साथी एक जगह इकट्ठे होकर हम लोग बैठकर परामर्श करें और इसकी चिंता और चर्चा करें। पर मेरा आपसे आग्रह है कि आपकी जिम्मेदारी इसमें, बीमारी अगर मानते हैं तो इस बीमारी के इलाज की तो है ही है, पर कॉन्फिडेंस बिल्डिंग की ज्यादा है। आप जो मरीज आए वो आपसे बहुत ही प्रसन्न और संतुष्ट होकर जाए, ये मानकर ना जाए कि उसे ऐसी बीमारी हो गई है कि जिस बीमारी का कोई इलाज नहीं है। तो मैं इतना ही कह सकता हूं, क्योंकि इतने वर्षों में मैंने इतनी दवाई खाई है, कोई दवाई छोड़ी नहीं है, पर कुछ इलाज बहुत महंगे हैं। यहाँ पर मैं उल्लेख करना चाहूंगा, दिल्ली में डॉक्टर जी के कार्यक्रम में हम गए थे, उनके अस्पताल में भी गए थे। वो महंगा इलाज था बहुत। वास्तव में जिस प्रकार का ट्रीटमेंट उन्होंने दिया, और अल्ट्रावायलेट रेज का ही दिया था, पर वो हमारी समझ में आता है। मैंने एम्स में डॉक्टर कार की बहुत इलाज लिया, पर वो अच्छी बात बताते थे। पर मेरा आग्रह है कि हम मानसिक रूप से अगर सही दिशा नहीं देंगे तो इस बीमारी को हम दुरुस्त नहीं कर पाएंगे, इसकी हम उस प्रकार से चिंता नहीं कर पाएंगे। तो साथियों, मैं कोई और ज्यादा बताने की उसमें नहीं हूं, पर आप सभी चिकित्सकों का बहुत बहुत मैं धन्यवाद दूंगा कि आपने मुझे अपने बीच में बुलाया। मुझे अच्छा लगेगा कि दोबारा फिर कभी आप हमारे पास आकर बैठेंगे और कभी और विस्तार हम इस पर बात करेंगे, क्योंकि इसमें जो भी आप अपेक्षा मुझसे चाहेंगे, मैं हर प्रकार की मदद के लिए हर समय तैयार रहूंगा, सहयोग के लिए हर समय तैयार रहूंगा। तो मैं केवल इतना कह सकता हूं, आपने मुझे बुलाया, और वास्तव में जैसा मैं शुरू में ये कहा कि आप चिकित्सक भाइयों ने एक जो बीमार व्यक्ति है उसको अपने बीच में बुलाकर एक मेरा सम्मान बढ़ाने का काम किया है, तो मैं आपका बहुत बहुत आभारी हूं। तो पर मेरा मानना है कि कुछ बातें हमारी समझ में आती हैं, सवाल जवाब भी आप जो करेंगे वो भी समझ में आता है, पर यह है कि मैं ये महसूस करता हूं कि कुछ बातों में तो आपको समझाना पड़ेगा। कोई भेदभाव का कोई मतलब नहीं है, बिल्कुल आत्मविश्वास बनाए रखने का काम करना चाहिए। और विटिलिगो के जो पेरेंट्स हैं उनको भी बच्चे की चिंता कायदे से करनी चाहिए। अगर वो चिंता नहीं करेंगे तो वो अपने बच्चे का एक दिशा में एक सही काम नहीं कर रहे हैं। तो मैं कोई बहुत सारी बात कहने यहाँ पर खड़ा नहीं हुआ हूँ। अगर कोई साथी कोई मुझसे प्रश्न पूछना चाहे तो उसका स्वागत है, पर यह है कि आजकल कुछ भी असंभव नहीं है। आज के दौर में हमारे एक साथी कहा करते हैं, कौन कहता है कि आसमां में सुराग नहीं हो सकता, एक पत्थर तो तबीयत से उछालो यारो। तो मेरा आग्रह है कि ये बीमारी ऐसी नहीं है, इसका कोई इलाज नहीं है, पर आप लोग अगर चाहेंगे तो इसका एक सही दिशा में जाकर एक सही स्वरूप लेकर काम करेंगे। तो मैं अधिक न बोलते हुए आप सबका फिर से धन्यवाद देते हुए, अगर कोई मुझसे पूछना हो तो आप सबका बहुत बहुत स्वागत है। धन्यवाद।
धन्यवाद मंत्री जी। आपने कहा कि आप धन्य हो गए कि हमने आपको यहाँ आपके रूबरू आए, बट हम धन्य हो गए कि किस तरीके से, जिस तरीके से एक विटिलिगो पेशेंट बता पाया कि उसका किस जीवन काल के अंदर क्या क्या उसने देखा, क्या क्या उसने कराया, और किस तरीके से लोगों के बीच में इसके लिए क्या क्या मिथ्स हैं, वो अगर एक आपके यहाँ समक्ष होकर आपके मुंह से घर घर लोगों तक ये बात पहुंचेगी तो वो भी समझेंगे कि ये बीमारी के लिए सिर्फ देखने में ही खराब है और कोई चीज इसके अंदर आपको शरीर को कोई नहीं करता, आप जो भी चाहें वो प्राप्त कर सकते हैं। एक अति साधारण पृष्ठभूमि के बाद और त्वचा के इस रोग विटिलिगो से पीड़ित होने पर भी आप आज जिस ऊंचाई पर पहुंचे हैं और जिसकी बारे में एक आम आदमी कल्पना भी नहीं कर सकता, तो क्या आपकी राह में कोई रुकावटें या अड़चने आई?
नहीं, ऐसा नहीं है। मैं शुरू से ही सक्रिय रहा था और पढ़ते समय मैं इमरजेंसी लग गई थी और आज महत्वपूर्ण दिन है। आज ही के दिन आपातकाल तत्कालीन प्रधानमंत्री के द्वारा लगाया गया था और मैं एक सप्ताह के बाद 1 साल के लिए जेल चला गया था। तो इसलिए हमारा कार्य का क्षेत्र बदल गया और कभी इस बीमारी को हमने महसूस करने का काम नहीं किया अभी तक। इतना ही कह सकते हैं। पर ये
कभी आपको विकास पुरुष भी कहा जाता है कि जब विकास की बात आती है तो आप सब कुछ भूलकर सिर्फ अपने क्षेत्र के लिए, अपने देश के लिए कार्य आपने किया है। और जिस तरह आपने, जब आप बता रहे थे कि विटिलाइगो के बारे में सर्जरी भी होती है और लोग बाहर जाके सर्जरी करते हैं, तो मैं आपको ये बताना चाहूंगा कि जो हमारी ये संगठन है उसके अंदर अगर देखा जाए तो पूरे विश्व भर के अंदर सबसे ज्यादा सर्जरी के बारे में अगर कुछ काम होता है तो वो हिंदुस्तान में होता है विटिलाइगो सर्जरी के बारे में। और हमारे देश के कोने कोने से ऐसे कई हमारे मेंबर हैं जो कि विटिलाइगो सर्जरी के ऊपर काम कर रहे हैं। तो मैं ये जरूर कहना चाहूंगा, जहां आत्मनिर्भर भारत की बात आती है तो विटिलाइगो सर्जरी एक ऐसी चीज है जिसके लिए जो भारत है वो आत्मनिर्भर है कि हम यहाँ बेस्ट से बेस्ट सर्जरी अपने पेशेंट्स को दे सकते हैं जिनको उसकी रिक्वायरमेंट हो। और आपके माध्यम से मैं ये भी बताना चाहूंगा कि समय समय पर लोग जो हमारे संगठन के मेंबर हैं, जो सदस्य हैं, वो फ्री में भी उपचार करते हैं लोगों का। और कई ऐसे हॉस्पिटल हैं जिस तरह एम्स हुआ जहां फ्री में इलाज होता है, जहां तक कि सर्जरी का भी सवाल है। मंत्री जी, क्या विटिलाइगो के कारण आपको किसी भेदभाव का कभी सामना करना पड़ा है या कभी इससे आपके कभी आत्मविश्वास डगमगाया हो? तो अनुभव अगर ऐसा हो तो साझा करें, क्योंकि समूचा भारतवर्ष आपको आज देख रहा है, जो हमारे मेंबर्स हैं, जो हमारे सदस्य हैं। और वेबिनार का एक अच्छा चीज ये भी हुई है कि अगर हम कहीं कॉन्फ्रेंस करते तो वहां 1000, 2000, 3000 लोग आते, तो आज वेबिनार के माध्यम से कोने कोने हमारे देश के अंदर जो डर्मेटोलॉजिस्ट हैं वो आपको देख पा रहे हैं और सुन पा रहे हैं। तो आप उनको क्या बताना चाहेंगे?
जैसे मैंने कहा था कि मेरी पूरे देश के अंदर पहचान बन गई है। पूरी पार्टी और जो लोग भी इस राजनीतिक क्षेत्र में सक्रिय रहते हैं सब मुझको मेरे नाम से पहचानते हैं। और मैं तो अब जैसे मुझसे कोई कहता है कोई दवाई आप खा रहे हैं नहीं खा रहे हैं, मैंने कहा कि दवाई नहीं खा रहे हैं, क्योंकि हमारी अब पूरे देश के अंदर एक अलग पहचान बनी हुई है। मैं ऐसा महसूस करता हूं कि अब हम उस फेज से बहुत ऊपर निकल गए। और मैं सभी श्रोता भाई बहनों से आग्रह करूंगा कि वास्तव में अपने कॉन्फिडेंस को कम करने का काम ना करें। जिस क्षेत्र में हम काम कर रहे हैं उस क्षेत्र में काम करें। ये मैं महसूस करता हूं कि बाकी बीमारियां ऐसी होती हैं कि हम जिसकी कल्पना नहीं कर सकते हैं। मेरे पास, मैं दिल्ली में रहता हूं और बरेली से दिल्ली तक मैं बहुत मरीजों की चिंता करता हूं और उन जो बीमारियां लोगों की देखता हूं और सुनता हूं तो मैं कल्पना नहीं कर सकता हूं कितने भयंकर बीमारी और कैसे सही होगी। पर मैं सभी श्रोता भाई बहनों से आग्रह करूंगा कि नंबर 1 मेरे मन में तो यह है कि ये कोई बीमारी नहीं है, क्योंकि हिंदुस्तान दुनिया भर में आप देखें तो काले और गोरे सब जगह हैं। और अगर आप बिल्कुल काले लोगों को देखो तो आपको कल्पना भी नहीं होगी कि काले कितने ज्यादा काले हो सकते हैं। और व्हाइट लोग भी जो हैं, जब उन व्हाइट लोगों का आप देखोगे तो उसकी भी आप कल्पना नहीं कर सकते। पर मेरा मानना यह है कि हम सबको महसूस करना चाहिए और खास तौर से अगर कोई प्रभावित हो गया है तो उसके परिवार वालों को समझ में आना चाहिए। जैसे मुझको शुरू में किसी ने बताया कि अगर दूध और मछली साथ साथ लो तो हम तो पूरे शाकाहारी हैं, हम प्याज भी नहीं खाते हैं। और ये बताया मुझको कि खटाई खाने से बीमारी बढ़ जाएगी। हमने खटाई भी बंद कर दी। हम कोई ऐसी चीज नहीं खाते हैं कि जिसको हमें कोई बताए कि खाएंगे तो इससे बढ़ जाएगा। और मुझे लगता नहीं, परमात्मा की हम पर कृपा है, सब ठीक चल रहा है। इतना ही मैं कह सकता हूं। पर मैं आप लोगों के माध्यम से सभी जो साथी इस समस्या से, मैं समस्या ही है, से प्रभावित है, तो वो एक बिल्कुल मेंटल फ्री होकर काम करें और कॉन्फिडेंस में कमी आ जाए तो हमको कभी भी टेलीफोन से बात कर सकते हैं, या दिल्ली में हमको चाहें हमको मिलने भी आ सकते हैं। अपने कॉन्फिडेंस को कम दिशा में ले जाने का काम ना करें, ये मेरा सभी से आग्रह है।
मंत्री जी, विटिलाइगो के पेशेंट्स की डॉक्टर से क्या अपेक्षाएं होती हैं? डॉक्टर्स द्वारा विटिलाइगो पेशेंट में कैसी बातचीत होनी चाहिए, और आपका सुझाव क्या रहेगा कि हम बेस्ट टू बेस्ट विटिलाइगो ट्रीटमेंट दें? तब भी क्या पेशेंट जो है वो कुछ और भी चाहता है कि ना केवल बीमारी दवा के बारे में बात की जाए, बट कुछ उसके मनोबल के बारे में भी बात की जाए, कुछ उसके जरूरतों के बारे में भी बात की जाए?
ना, डॉक्टर को तो पहला काम ये करना चाहिए, उसका कॉन्फिडेंस बनाने का काम करें। खाली ये मानकर ना चलें कि वो आपका मरीज है, उससे आपको दवाई देनी है और उससे पैसे लेने। और अगर आप ये काम करेंगे, क्योंकि मैंने ऐसा महसूस करा है कि विटिलिगो अगर हो जाए तो 100% आप नहीं कह सकते बिल्कुल सही हो जाएगा। कभी कभी हो भी जाता है, अक्सर नहीं होता है। तो फिर डॉक्टर के बारे में वो अपनी राय खराब ना बनाए। मेरा आग्रह है कि मरीज को अपने परिवार का व्यक्ति मानकर उस मरीज को अच्छी सलाह दें और उसके अंदर कॉन्फिडेंस बिल्डिंग करवाएं, और ऐसे लोगों की जानकारी दें कि जो इस बीमारी के रहे और जिन्होंने समाज में अपना स्थान बनाने का काम किया है, कि ये कोई बीमारी नहीं है। पर कोशिश करें, क्योंकि मैंने देखा एक बीमारी से कभी कभी सही भी हो जाते हैं और कभी कभी समस्या बढ़ जाती है।
बिल्कुल मंत्री जी, जितना आप कह रहे हैं, अगर हर विटिलाइगो पेशेंट ये समझ जाए कि डॉक्टर अपनी तरफ से पूरा जो योगदान दे सकता है, पूरा जिस तरह की बेस्ट टू बेस्ट दवाई दे सकता है, बट कई चीजों पे निर्भर करता है कि कितना रंग आएगा, कितनी जल्दी आएगा, और कई बारी नहीं भी आता। मंत्री जी, ज्यादा आपका समय ना लेते हुए मेरा लास्ट प्रश्न यही रहेगा कि आज 25 जून विटिलाइगो डे है, और आजकल जिस तरह डॉक्टर को कोरोना वॉरियर कहा जाता है, हम सारे डर्मेटोलॉजिस्ट भी विटिलाइगो वॉरियर्स हैं। आजकल कोरोना वॉरियर्स तो बहुत प्रचलित है, बट विटिलाइगो वॉरियर्स जो है, जो कि हम विटिलाइगो के लिए ट्रीटमेंट देते आए हैं और देते रहेंगे अपने पेशेंट्स को, अपने हम उसके प्रति प्रतिबद्ध हैं। बट आप डॉक्टर समुदाय के लिए कुछ विशेष संदेश देना चाहते हैं आज विटिलाइगो डे के ऊपर, और 1 जुलाई को डॉक्टर्स डे भी होता है
ना। 1 जुलाई को डॉक्टर्स डे होता है, बात दुरुस्त है। विटिलिगो वॉरियर्स बनकर आप लोग काम करें, आपकी पहचान रहे, मेरी शुभकामनाएं आपके लिए। और मैं इतना ही कह सकता हूं, ये ऐसे क्षेत्र में आप काम कर रहे हैं, वास्तव में ये बीमारी नहीं है। उस मरीज को अगर आपने मानसिक रूप से स्वस्थ कर दिया तो वो हमेशा आपको याद रखेगा। और मेरा आपसे आग्रह है कि इस काम में आपको ये जो समस्या का आप इलाज कर रहे हैं, इसका कोई ऐसा सिलसिला नहीं है कि कोई आपसे नाराज हो जाए, पर ये वास्तव में आप अगर उसको प्रेम से रखेंगे तो आपके फैमिली का मेंबर भी बनेगा। और मेरा आप सभी भाइयों के लिए और सभी बहनों के लिए बहुत बहुत शुभकामनाएं। एक अच्छी दिशा में आप लोग काम कर रहे हैं, समाज को एक सही स्वरूप में ले जाने का काम कर रहे हैं, और मानसिक रूप से कैसे ये मरीज महसूस करें। क्योंकि मैं समझता हूं कि हमारे देश की आबादी के हिसाब से यहाँ पर कम से कम 1-2% भी अगर ये प्रभावित मरीज हुए,
2% प्रभावित है,
हाँ, बड़ी संख्या है। इसको ठीक ढंग से कराने का काम करें। तो मैं, आपने मुझे बुलाया, इसके लिए आपका बहुत बहुत आभार। और मैं इतना ही कह सकता हूं कि इस समस्या को हम सब लोग मिलकर दूर करेंगे, पर अपने मन को दुरुस्त करने का काम करें, मानसिक रूप से स्वस्थ रहने का काम करें। और मुझे लगता नहीं ये कोई बीमारी है। आप कभी भी जो भी साथी हमसे मिलने आना चाहे मिले, कभी आप ओपन कॉन्फ्रेंस करें या बुलाएं, हमें बुलाएं, तो हम कब आ सकते हैं आपके इतने, जब भी आप बुलाएंगे।
धन्यवाद मंत्री जी। तो हम इंतजार करेंगे कि कब हम आपसे रूबरू हों, और हमारी जो नेशनल डर्माकॉन होती है या स्टेट क्यूटिकॉन होती है, उसके अंदर भी हम आपसे विचार विमर्श करें, हम आपके बारे में और जाने, विटिलाइगो के बारे में। जिस तरह आज आपने समूचे भारतवर्ष के जो चर्म रोग विशेषज्ञ हैं उनको आपने बताया कि किस तरीके से एक रोगी जो होता है, वो अगर डॉक्टर उसका साथ दे तो कहीं भी पहुंच सकता है, कुछ भी कर सकता है। ट्रीटमेंट के साथ हम उसको जो कॉन्फिडेंस है वो देने का काम करते रहे हैं और करते रहेंगे। मंत्री जी धन्यवाद, आप यहाँ आए और आपने हमारा मार्गदर्शन किया इस विटिलिगो डे के ऊपर। समूचे भारतवर्ष से IADBA दिल्ली स्टेट ब्रांच की तरफ से मैं आपका आभारी हूँ। धन्यवाद।
थैंक यू, आपका बहुत बहुत धन्यवाद। अब दोबारा जब भी आप बुलाएंगे तो हमें अच्छा लगेगा कि हम आपके लिए हर समय तैयार रहेंगे।
थैंक यू मंत्री।
नमस्कार।
नमस्कार।
पूरी बात आपसे करना चाहती हूँ। बहुत सारे लोग विटिलिगो को कुष्ठ रोग यानी कि लेप्रेसी के साथ संबोधित करते हैं, जो कि बिल्कुल भी नहीं है। उदाहरण के तौर पर देख सकते हैं, ये एक मरीज है जो कि विटिलिगो से प्रभावित है और ये एक मरीज है जो कुष्ठ रोग यानी कि लेप्रेसी से संक्रमित है। जैसा कि आप देख सकते हैं, इन दोनों बीमारियों में काफ़ी अंतर है। फिर भी बहुत सारे लोग सफ़ेद दाग की वजह से सामाजिक भेदभाव के शिकार बनते हैं, जो कि बिल्कुल भी नहीं होना चाहिए। तो यहाँ पे हमारा कर्तव्य ये बनता है कि हम इन मरीजों के साथ खड़े हों और इनका आत्मविश्वास बढ़ाएं।
Vitiligo doesn't spread. It's not infection. It's not a cancer. Understanding this is the key. The people who have vitiligo are as healthy as you and me.
विटिलिगो या सफेद दाग की बीमारी आनुवंशिक नहीं होती है, यानी कि वो माँ बाप से उनके बच्चों को हो या एक परिवार के सारे लोगों को, ऐसा बिल्कुल भी जरूरी नहीं है। ज्यादातर 85 से 90% मरीजों में वो अपने परिवार के पहले और आखिरी विटिलिगो प्रभावित व्यक्ति होते हैं।
Many patients falsely believe that vitiligo is often caused by consuming milk, fish and sagu, which is not correct. Diet has no role in causing vitiligo. A patient suffering from vitiligo should rather consume a normal healthy diet. Vitiligo is a disorder which is limited to the skin and it does not affect your physical or mental abilities. In some cases, vitiligo might be associated with underlying thyroid disease, anemia or diabetes, which can be easily diagnosed and treated by your doctor.
One of the myths associated with vitiligo is it is life-threatening. But the fact is, it is not. People diagnosed with vitiligo lead a normal life, just like anybody else. So I want you to know and understand that vitiligo is absolutely not life-threatening and anyone with it can lead a perfectly normal life.
सफेद दाग पूर्णतः ठीक हो सकता है। दवाइयों की मदद से हम इससे पूरी तरह से मुक्त हो सकते हैं, बशर्ते हम अपने चिकित्सक की बात सुने, समय समय पर उन्हें दिखाएं ताकि इस बीमारी का निवारण हो सके। अतः हमें इससे डरने की बिल्कुल कोई जरूरत नहीं है, क्योंकि यह लाइलाज नहीं है। धन्यवाद।
Thank you, Dr. Anuva. I would now request Dr. O.P. Gangwani, sir, and Dr. Vinay Singh to announce the winners of the poster competition that was held for the residents of Delhi. Over to you, Gangwani, sir, and Dr. Vinay.
Thank you, organizers. We got 14 entries for the poster, namely from Dr. Abhishek Bhagwat, Dr. Neha Taneja, Dr. Akanksha Agrawal, Dr. Damini Verma. Am I audible, na?
Yes, sir.
Dr. Mona Lisa, Dr. Neha Chauhan, Dr. Aneet Kaur, Dr. Bhavishya Sethi, Dr. Ruchika Singh, Dr. Anjali Bagrodia, Dr. Soumya Sachdeva, Dr. Ishita, Dr. Ananya Sharma, and Dr. Monisha Bhandari. I have given all the names so that there should be no confusion that we might have missed any entry. These are the 14 entries which we have reviewed. Dr. Vinay Singh and myself agreed for giving some awards, and we agreed that for the second prize there are two eligible candidates for the second prize. There was a tie for the second prize. So second prize goes to Ruchika Singh of Safdarjung Hospital and Mona Lisa of Maulana Azad Medical College. So these are the two. This is of Mona Lisa Gupta and Ruchika Singh. This is of Ruchika Singh. This is for second prize. And the winner of the first prize is Dr. Ananya Sharma of AIMS, his originality, and I wanted to know whether he has drawn it by his hand, whether she has drawn it by the hand, by her own hands. Very well, very good, very original, and we found it that it carries the right message in the right way, and right. So Dr. Ananya Sharma for the first prize, Dr. Ruchika Singh and Dr. Mona Lisa for the second prize. But all the entries were very good. We liked all the entries, and we appreciate, and we really would encourage all our residents for the good work they have done. So, and the winner is Ananya Sharma. Thank you, Dr. Gulima.
Thank you, sir. Thank you, sir, and thank you, Dr. Vinay Singh, for assessing the posters. We will now move on with our scientific program. And to introduce our guest of honor and keynote speaker today, it is my proud privilege to invite Dr. Sanjeev Kandhari to welcome the keynote speaker. Dr. Sanjeev Kandhari is a practicing consultant dermatologist with 38 years of experience in both teaching as well as in practice. He was the associate editor of the IGDVL and a reviewer of the same, and also the Indian Journal of Dermatology. He has published numerous articles in various journals and has written several chapters in dermatology textbooks. He has also authored 2 books. He was appointed the National Professor of Dermatology by the IMACGP on 2 occasions. He has held several administrative posts of the IDVL and is a member of several national and international academic societies. He is also actively involved in social work. I welcome Dr. Kandhari, sir, to please introduce Dr. Iltifat Hamzavi, our guest of honor and keynote speaker for today.
Thank you, Dr. Gulima. Can you hear me?
We can hear you. You could start your video, sir.
Okay. The host has stopped it.
Could we request this host to please start Dr. Kandhari's video, please? Okay, sir, you could go on, I think. We'll have your video on.
Sir, we welcome you to today's World Vitiligo Day CME webinar from New Delhi. There could be no better person than Dr. Hamzavi.
on vitiligo. He's been the co-chair in the Vitiligo International Symposium, Detroit. He's also had a postgraduate training in lasers and photomedicine in Vancouver. He's got peer-reviewed publication on vitiligo and also written review articles on vitiligo. He's got to his credit a handbook of vitiligo, which he wrote in 2015 and again in 2008. He's had many invited lectures on vitiligo. Besides vitiligo, he's done work on hidradenitis suppurativa, rosacea, photomedicine and pigmentary disorders, atopic dermatitis, psoriasis, and so on. Sir, we welcome you, and we'd like to hear from you what's new in the medical therapy of vitiligo.
Well, it's such a pleasure to see my Indian family again, my dermatology family, which I have grown up with in many ways. So thank you so much for the introduction. And so the organizers wanted me to kind of focus on an update on vitiligo. And I just want to do a quick sound check to make sure that you're able to hear me and the connection is okay.
Yes, we can hear you.
Great. So, so in honor of World Vitiligo Day and this whole week in the United States, we've been having celebrations, and unfortunately, as you know, we're having some challenges with some social unrest and the COVID situation. So it was supposed to be in Minneapolis this week, and I'm supposed to be there right now. But unfortunately, I'm here with you, and we'll be doing the Minneapolis meetings on Saturday virtually. There's also Vitiligo Days going on in South Africa that we're supporting in central parts of Africa, other parts of Asia. So I really commend the Indian community for really taking the lead. And I'm offering you updates, but in many ways, the transfer of knowledge has been in both sides, and sometimes it was much more towards Indian side, and I thank you for your efforts in this work here. One of the references I often use is about vitiligo is white patches that bruise the soul, and we know how difficult vitiligo is. In my own country, I have to explain how difficult the quality of life is for vitiligo, but among an Indian population, I don't need to do that. Need to reveal or disclose my various relevant conflicts of interest. I'm actually kind of proud of the fact that there's more and more companies who are interested in this field, and there's even more material coming out. So I'm hopeful that I can share some of those concepts with you. This is my hometown of Detroit, Michigan, a beautiful city that's really growing, has gone through some very, very difficult times. It's also the home originally of Malcolm X. He's called him Detroit Red, and we're very proud of the fact that we embraced our African-American community. We're the largest population of African-Americans as a percentage in the United States, and that population really drove vitiligo research, and they were some of the founders of the unit that I'm part of in Detroit. So the social cannot separate from the academic in this context, and the fact that the United States is really driving vitiligo research comes from our desire to kind of treat all Americans and hopefully all people in the world specific to their concerns about their skin. As you know, vitiligo affects about 0.5 to 1% of the world population, and it's important to understand the pathophysiology of vitiligo. So I have two slides that I'd like to kind of cover in the next 10 or maybe next 2-3 minutes. And so the way I view vitiligo and the way that many people are viewing vitiligo is that there is a stress component that's oxidative. Then there is an immune component that is probably triggered by the JAK-STAT pathway, at least involves that. And then there's a defect in some kind of melanocyte migration or melanocyte development. So there's an oxidative stress somewhere in the keratinocyte, the melanocyte, and then you have a activation using the JAK-STAT pathway of the CD8 T cells, which ultimately cause a destruction of melanocytes. As long as the rate of repigmentation matches the rate of depigmentation, you have normal pigmentation. But at some point, the rate of depigmentation is faster than the rate of repigmentation, and that's when you get this depigmentation. So that's where the melanocyte migration pathways come into play. And in this diagram, I try to emphasize that where, again, if you have this normal migration, you can replace the melanocytes that are destroyed via the follicular apparatus, then you don't get the depigmentation. And going back to this slide, this pathway is an area of rapid investigation, and we'll talk a little about the JAK inhibitors as well as IL-15 pathways. In addition, there's also some work using alpha-melanocyte and elements to try to build up the melanocyte reservoir so they become a hardier structure, we can replace them. But there is very little except for one small paper, which I want to present today, talking about the initial event. Why does vitiligo happen? In medicine, we're very good at describing symptoms and then treating the symptoms and looking at the molecular processes that are behind them. But what is the initial trigger? And in some ways, we have to go to other traditions. And I've always been fascinated by the Ayurvedic and Unani traditions. When I came to India several years ago, I visited several Ayurvedic and Unani hospitals, and they attempted to kind of bring an overview of why diseases occur. I think allopathic medicine has to kind of look at that. But since we're experimentally designed, we have to go into silos and look at pathways, look at melanocyte migration. But why is this all happening? There's some theories I'm going to present and try to cover that in the next few areas. So melanocyte stress, initial defect. Keratinocyte adhesion defects are also a factor, results in immunopathogenesis as well as the melanocyte defects. So that's the event, immunopathogenesis, and then the pigmentary system has some defect that does not allow the migration of the melanocyte. Here's a little more detail about the actual molecular pathways involved in immunopathogenesis developed by John Harris, and this was presented in our JAD CME from about 2-3 years ago, which we're in the process of updating. And so John has been incredible. John Harris from the University of Massachusetts has been incredible in developing a lot of science, along with Julian Seneschal and other investigators from Europe, and then Devinder Prasad in your country has done quite a bit of work in the immunopathogenesis and melanocyte destruction. But at its core, the interferon gamma pathway is the initial trigger. And at some point, the JAK pathway is triggered by CCXL 9 and 10 levels to cause T cell recruitment. When the T cell recruitment occurs, then ultimately you have melanocyte destruction. If you can affect interferon gamma, if you can prevent the JAK1/2 secretion in skin cells, in keratinocytes, from producing the CXCL 9 and 10, especially CXL10, you can prevent the T cell recruitment. Now, I want to emphasize to you that the JAK pathway is occurring in keratinocytes. People keep referring back to keratinocytes and the T cells. Yes, the cell you want to impact is the T cell, the CD8 activated T cell, but the secretion of the JAK-STAT pathway is occurring in the keratinocytes. That's why keratinocyte application of these topical medications be helpful. And again, a slightly clearer version of this whole pathway. Now, most American dermatology residents do not like pathophysiology. I hope I'm not boring you, but if I don't cover this, it'll be hard to pick up some of the new advances. So in the next couple of minutes, I want to cover discussions about JAK inhibitors. I'd like to talk to you about the kind of underlying antimicrobial microbiome elements. I'd like to talk about alpha-melanocyte, as well as briefly touch upon some new light sources. But if the pathophysiology is understood, you can understand the next components of the talk. JAK1, 2, 3, and TYK 2.3 are the key pathways you want to discuss. There are nuances. You will find JAK1 and 3, you'll JAK2 and 3s, you'll find JAK1s and 2s, and you'll find TYK inhibitors. All these terms are terms I suggest you pick up because there's active clinical studies going on. If you go to clinicaltrials.gov, you will find a variety of JAK1 and 2, a JAK1 and 3, you will have a JAK2 and a TYK2 inhibitor all being studied, and Henry Ford is actively working in some of those areas. Other sites are also doing work. This is Dr. Lim, my chairman at Henry Ford, and Dr. Louis, my mentor at the University of British Columbia, two incredible giants in dermatology for me. And he really helped me grow my interest in vitiligo. Another interesting area of vitiligo that I wanted to bring up to you is this quick paper from South Korea, Dr. Bai, showing that there's reduced rates of internal malignancy. What is the internal trigger? Why is vitiligo happening? Well, could this be a potential explanation? And then this is the other question I had. Going back to my own heritage of being a South Asian, I'm very interested in what South Asia, India, Pakistan, Bangladesh, Sri Lanka all did in this whole area. But this is a paper that tries to get down to why is vitiligo happening. And Carolyn LaPoule, as many of you know, is one of the world experts in vitiligo's pathophysiology. She's helped study the heat shock protein, which seems to trigger the initial immune response. But she had this very nice paper in our top scientific journal, the Journal of Investigative Dermatology, that I know many of you are aware of, looking at antibiotics. When you expose animal mouse models to ampicillin, you seem to get a different response when you expose them to neomycin. And specifically, when they looked at the microbiome of the gut, it changed. The microbiome of the skin did not change, and ultimately that resulted in vitiligo in about a third of the animal models. Point being, microbiome of the gut seems to have an impact on vitiligo. And that goes back to the traditions of Unani and Ayurvedic medicine. In those areas, we would keep talking about diet. What exactly is the role? We need rigorous to do that. And one of the challenges we have in medicine is what are the markers of diet that we have to change? People come to me all the time, and sure, they come to you about diet. There's a role, we just don't know what it is. But this is an initial insight, a very nice paper to review about some of the advances. The VASI score is something that you should also pick up, because the VASI score is the primary endpoint that is being used by the FDA to assess the evidence behind these treatments. And the VASI score is something that I helped develop with Dr. Harvey Liu and his team when I was at the University of British Columbia. And it looks at a palm unit, it looks at the degree of pigmentation, you multiply them, and you get a score 0 to 100. And most of the scores, like the PASI, you want to look at the degree of difference. So you look at the rule of nines, and the VETF is another scoring system, the VETI is another one, and then the VASI, and you basically break the skin down into different percentages. You measure it out as far as the degree involved, and then for each zone, you look at the degree of depigmentation. This is an example of schematic developed with Dr. Yuji Yamaguchi, and it basically takes the original VASI paper in JAMA 2004, and it looks at this from a schematic perspective. So you want to look at this with anchors. 50% depigmentation. Is the rate of depigmentation equal to the degree of repigmentation? Is the color equal to depigmentation? We developed it, we had anchors. People can pick up complete depigmentation, they can pick up 50%, and they can pick up 10%. So you always ask your question, is there more or less pigment than depigmentation? If it's equal, it's 50%. If there's more depigmentation, you're already above 75%. If there's a greater degree of repigmentation, you're at 25% or so. So again, anchors, equal, right, at 50%, more pigment, then you're at the 25% or lower, more depigmentation, 75% or greater. And you use that, multiply with the area, get down. So the VASI score is something you understand. You've applied it both in surgical elements, phototherapy, as well as the drug development, and we'll cover that in the next few minutes. Also, please don't forget the other elements. Again, the Indian community is very, very strong in vitiligo, but you know all these options. But in the United States, you kind of review these areas, but discuss those with your patients. So what is the degree of depigmentation? Now, the other thing that's come up is that there's another scoring system called the VES, which is developed in Europe, that's also being used as a secondary endpoint. It's a much easier process to quickly pick up the degree of pigmentation. You look at the distribution and you can kind of come up with a measure. It has not been used in large-scale clinical trials. It's being used in several of the trials that are going on right now, and we'll see how robust it is. But initial review, it seems to have a higher degree of, it can pick up a higher degree of change than the VASI can, but it is a little harder to use initially, but I think that might be another scoring system that we develop. But the VASI and the VES are probably the two scoring systems linked back to quality of life. Going back into efficacy, how does phototherapy compare to standard treatments? In general, after 6 months of phototherapy, you can expect around a 42% improvement in the VASI. And that's important to know because as you get into other areas of vitiligo treatments, you have to compare phototherapy, 42% or so improvement to the subsequent treatments. And we have World Vitiligo Day, that was last year in Houston. We have World Vitiligo Day. These are some of the board members of the Global Vitiligo Foundation, Dr. Henry Lim, John Harris, Richard Huggins, Pearl Grimes, Amit Pandya, Kim Boyd, who's a patient with vitiligo, and Vicky Hart, another patient with vitiligo. And that's the group that kind of runs the Global Vitiligo Foundation, which will be supporting India when they do the VIS in Bangalore. Alpha melanocyte, that's one of the first treatments we talked about, melanocyte stress, melanocyte migration, alpha MSH agonist. You can expect significant degrees of repigmentation. This is a patient from that particular study with significant repigmentation. But with alpha MSH, you have to do phototherapy. And one of the challenges in the South Asian population is that culturally pigmentation is considered a different standard of beauty. And this caused a lot of tension in my country because there's been a lot of frustrations with some cultural perspectives. But pigmentation is not considered attractive to patients. And with this implant, you get much darker. If you look at this patient's baseline skin tone, she's much darker with the implant. But again, the degree of pigmentation is improved. It seems to work in the melanocyte pathway, but it's a slight immunosuppressive effect of these implants. And then after 15 treatments, you have significant improvement. And if you look at the actual combination group, which is over here, you have a combination group starts responding at 60 days at a much faster response. Initially at 30 days it's the same, but then the combination seems to improve, and the degree of improvement was greater on the VASI score on the combination group than it was in the phototherapy group alone. And you had about more than a 50% improvement on the combination group, and you had about a 25% improvement on the phototherapy alone. Now, what about some of the upcoming treatments? The JAK inhibitor studies are going to be published in a journal in the very near future. I'm allowed to kind of present the 24-week data. This was presented last year in Milan, and as you know, we talked about the interferon gamma, CXL9, and CXCL10 pathways in which you have the JAK-STAT process going on in keratinocytes. That secretion causes the CXLCN10 secretion, and ultimately the JAK inhibitors stimulate the T cell activity that destroys the monocyte. So you block this, you prevent the CD8 T cell from turning on. And so ruxolitinib is a potent inhibitor of JAK1 and 2. We talked about the various JAKs, JAK1, 2, 3, the TYK inhibitors. Well, this is JAK1 and 2, which seems to be the predominant driver of vitiligo. And so JAK1 and 3, tofacitinib in the initial studies showed some benefit, but subsequent studies hasn't been as effective. JAK1 and 2 seems to show more promise. So given this pathway, based on molecular studies and cell culture studies and then biopsies, John Harris and other groups were able to show that ruxolitinib in the lab seemed to have an impact. And so David Rose-Marin published a paper a few years ago showing that it was effective, and then helped us devise this trial with Insight to look at vitiligo mostly on the face, and it was vitiligo more than 0.5% total BSA had to be in the face, and you could use up to 3% of the total body on the rest of the body. So you had to have more than 3% on the body. You had to have more than 0.5% BSA on the face. These are the patients who were screened, and then here are the VASI responses. And so you can see that at 24 weeks, you have about a 45% improvement in patients. So this is the VASI 50. So about 43% of patients had 50% of their color back at the end of 24 weeks. This number improves greatly at 52 weeks. So it's a treatment that takes some time, but you do get a large degree of improvement with that. So now, what does that look like? Here's the VASI responses. This is no change in VASI. This is a 75% improvement in the VASI score. And about 25 to 30% of patients in the 52-week study ended up achieving this degree of improvement. And about 13 to 15% of patients achieved this VASI 90, which again is a significant improvement. So it kind of gives you an idea of what is a VASI 90, what is a VASI 75, and a VASI 50. Also had significant improvement of acral surfaces, which can be very tough to treat sometimes, and again, a very promising response. And here's some of the more common adverse reactions, pruritus and mostly topical reactions. No major systemic side effects that are present. In conclusion, the patients at week 24 had a VASI 50 of about 45% of patients achieved that, about 30% achieved the VASI 75, and then there was also a significant improvement in the physician global assessments. And again, alpha-melanocyte, I've already covered that. I also wanted to report some new studies on failure. So Apeloramass has a lot of potential of working, and there was a well-designed trial, a escape study done by Imran Majid from India that piqued a lot of interest. Dr. Passeron from France subsequently did some other studies, and in 2018 the VIS, as well as a recent paper that's published, they showed that Apeloramass does not work for vitiligo. So initial hope, but does not seem to be effective. So it's a negative study from Apeloramass, but it's really critical that people like Dr. Majid continue to do work in this area, publish it, so we can try. That's how medicine moves forward, as we all know, but it takes a lot of global effort to make that happen. Dreaming of a cure, IL-15 is a very promising agent that shows a lot of promise. And the microbiome, we talked about it, but IL-15 quickly is an antibody. It seems to activate memory T cells, and that's why vitiligo seems to occur in the same location continuously. So John and Amit and groups from their respective institutions did some work on this, and they were able to show that in the IL-15 group, you're able to reverse depigmentation, and that's all they did. No topical treatments. There are some upcoming studies going on with the Immune Tolerance Network, as well as John's private company studying IL-15. I don't have much time to cover new light sources, so I'm going to quickly refer to this, but we've done a lot of work on visible light and pigmentation. Multispectral light sources using visible and UV light seem to have a greater degree of improvement. We have some papers coming out on that topic, and I can take any questions on that. I want to thank my Indian vitiligo family. I know so many of you and have such a strong affection for many of you, and I've wanted to come to India for several years, but due to a lot of administrative issues, haven't been able to make it. But Dr. Molakar, who came to my country, the United States, to visit and help us set up our surgical unit, Devinder Prasad, Deepthi Gia, Imran Majid, all vitiligo pioneers of India, and so many of you are there and published and do great work. And here's just some pictures from our department and all the fellows, the team that goes into doing a lot of this great work. And Dr. Richard Huggins, who is one of the pioneer academicians in bringing patients to research, to advocacy. Dr. Henry Lim, our chairman, who helps us up. And then Dr. Ozak goes up. Again, I also done work with us and all the funding sources. This was all privately funded, and actually by two South Asian families, the Shahani family initially, the Hamzavi family, my family's foundation, Dr. Lim and Living Good, all personal funds that result in this research. And this is my wonderful South Asian family in the Detroit area celebrating graduation. So thank you for your time. I hope I didn't run over time. I'm happy to take a few questions.
Thank you, Dr. Hamzavi. That was really wonderful. I wondered, Gulima, if we have time for one or two questions from Dr. Hamzavi or no?
Yes, sir, definitely. If you would like to put any questions forth, please do. I'll just check if there are any live questions. We do have time, sir.
Yes. You've mentioned about JAK inhibitors cream, which has not come to India. What's your experience with the oral JAK inhibitor in vitiligo?
So in clinical, it's been hit and miss. We haven't had great results with tofacitinib just in clinic. And so it's expensive medication. We have some patients who've been paid for in cash, and they've used it, and we haven't had dramatic results. Initial report by Dr. King out of Yale suggested improvement, but subsequently it seems that you need to have some source of light to make it work. So not great. I have not used oral ruxolitinib, but there are papers using oral ruxolitinib with some success.
Any other questions, Gulima?
No, sir, there are no audience questions.
Okay. Then with that, I'd really like to thank Dr. Hamzavi for his time. Thank you very much, sir.
Thank you so much.
Thank you, Dr. Kandhari, sir, and thank you, Dr. Hamzavi. Moving on with the program now, we've got two panel discussions coming up. And for the first one, I would like to invite our chairpersons, Dr. V.K. Sharma, sir, and Dr. Vineet Ralhan. They will introduce the moderator for the first panel, which is on the medical management of vitiligo, which is going to be moderated by Dr. Rohit Batra. Dr. V.K. Sharma is the professor and head of the Department of Dermatology and Venereology at AIIMS, New Delhi. He has an over 5-year-old teaching, research, and patient care experience. Sir has a lot of books that he has authored. He was the president of the IADVL Delhi State Branch. He was also the president of the IADVL in 2009. He is very well decorated with several awards. His special interests are skin allergy, vitiligo, eczema, among others. Welcome, V.K. Sharma, sir. Our next chairperson for the panel is Dr. Vineet Ralhan. Sir is an associate professor of dermatology at Maulana Azad Medical College, New Delhi. He has been the past president and secretary of the IADVL Delhi State Branch. He is the recipient of the Dr. K.C. Kandhari Award in 2019. Welcome, chairpersons, and over to you to introduce the moderator for this panel, please.
Thank you so much, Dr. Gulima, and it's our pleasure to chair this session on medical management of vitiligo. The moderator is none other than Dr. Rohit Batra. We all know Rohit. He is a consultant dermatologist and laser surgeon at Gangaram Hospital and director of Derma World Skin Clinics. He has been our past secretary of Delhi State Branch in 2013. He has been the national joint secretary also, as well as a chairman of the media cell of National IADVL. He is a master organizer, as we all know. He is the organizing secretary for the DAS Summits, Acne India, CAD Summit, and what all. And it's over to Rohit for a wonderful, I hope it's a wonderful session on medical management.
Thank you, Dr. Vineet Ralan, sir. And today, the first panel discussion is on vitiligo medical management, and I'd like to invite my panelists to switch on their cameras. Dr. Iltefat Hamzavi, Dr. Rashmi Sarkar, Dr. Binod Khetan, and Dr. Sujay Khanpur, sir. All of them are here?
Yeah. Yes. Can you hear me?
Yeah. Without wasting much of time, when we talk about medical treatment for vitiligo,
video is disabled. It's not. You cannot start your video because the host has disabled it. Rohit.
Yeah, but I am online.
No.
You could go to the left corner of your screen, and there's a camera button there. Just click on that. Your video will begin, sir.
Yeah, Rohit, you are audible and your slides are visible also. Please go on.
Thank you. So, Dr. Hamzavi, when a patient of vitiligo comes to us for management, for treatment, does counseling also is a very important step before we take the patient for treatment, say for medical management or surgical management?
I think it's absolutely critical. And in the United States, the FDA and the patient groups have had meetings have shown that the quality of life is ultimately the ultimate measure. So the VASI now has to the quality of life. So much quality of life, especially my South Asian patients, is dependent on acceptance. And I think that there's 2 points of treatment in India specifically that you have to address. One is we have to hit the pathophysiology. There's also a societal expectation. If somebody can feel accepted in their own family, in their own social circle, quality of life improves, which is measured by multiple vitiligo-specific quality of life indexes, some which have been developed specifically for the Indian population by India. Dr. Raman has one as well. So I would suggest that you use that as evidence, but counseling is critical. It's the first thing I do, and actually that's where I spend most of my time.
Okay, thank you. Dr. Rashmi, you see a lot of pediatric patients also. So does counseling vary as per the type of vitiligo, age, sex, profession, and socioeconomic class in India?
Yes, Rohit, I think it definitely does. Because we all know that regarding the type of vitiligo, if you have lesions, facial lesions, especially lesions, facial or mucosal, I'm talking about the lip lesions, the quality of life is, very much more impaired, as Dr. Hamzavi is saying, and nice to see you here, Dr. Hamzavi. So the thing is that it's important to treat that, the type of vitiligo, and you're also bothered about the acral vitiligo. Maybe that is where the counseling comes in, although it's quite resistant to treatment. The other thing is regarding, age. A child, may not be so much affected unless, he's really teased in school or in his peer group. That is important. His parents actually will be more concerned. The concern starts more in adolescence, I think, There's more peer pressure that time, or pre-teens. That is my reading into the thing. Sex, again, I think where women are concerned, women, ladies, or the female gender, there's going to be more anxiety, more need for aggressive treatment, especially if the girl is, again, reaching the marriageable age. Or, women, because the moment they have it, the entire family is devastated, that she's not going to get married. I think that's the main concern. Professionally, people, who are more in the public arena, people who are speaking, they're visible to the public, whether it's a public office or where you're using your hands, your face, everything like that, that is an area, where you may be affected. On the other hand, there's also a reverse thing here. Supposing you're more educated, I've also seen that people are now, less affected by the disease. Like I had a girl, very educated girl, her parents were affected. She was working in a multinational, but she knew about vitiligo and she said that I really couldn't care, less. I can use a bit of camouflage. So that is, I think, two ways of looking. The modern India is very much now, aware of the disease. Socioeconomic class, I think it's the higher socioeconomic class people, who may be a little bit more worried. With the poorer people, I think the concern is one girl, gets it out of a family of 5. Marriage is again an issue. That is when you have an entire family presenting to you, because we've had these people coming with the bridegroom asking for counseling. So that's in short, about all your points.
Thank you, Dr. Rashmi. Dr. Ketan sir,
Yes.
you come from one of the most premier institute of the country, and when a patient comes to you, you have a basket of everything that is available. And does it matter for you when a patient comes to you that his or her socioeconomic class is going to make a difference into what you are going to treat with medicines or surgery, because you have everything?
Yeah, so of course you have to individualize the treatment depending on the age of the patient, as Rashmi has said, depending on the profession of occupation of that patient, how far that patient is away from the facilities where, say, phototherapy is available or not available, whether the patient can follow up regularly, how much is the load on the psyche rather than on the skin. So these assessments are important, because diagnosing vitiligo is not difficult. Classifying also is not difficult, but what treatment plan will be suitable and the compliance will be good for one patient, that is very important to know.
Okay. Dr. Sujay sir, when we talk about stabilizing medication, what is your go-to drug in most of the patients?
Yeah, so in terms of activity of the disease, we classify vitiligo into a slow spreading vitiligo or a rapidly spreading vitiligo. And as per the guidelines of our IIDVL and our department, we like to go by the number of new lesions that have developed in the last 1 month and 3 months, which means if we are getting less than 5 new lesions in 1 month or less than 15 new lesions in 3 months, we like to call it as a slow spreading vitiligo. If there are more lesions than that, we call that there is rapid spreading vitiligo. And I like this classification, before I begin on the medical treatment of active vitiligo, I like this classification more than a classification, what has been referred to as the VIDA, that is the vitiligo activity score. And the reason is that the VIDA talks only about the duration at which the lesions have come, but doesn't talk about the number of lesions that have come. So if I see patients with rapidly spreading vitiligo, I would certainly like to initiate an agent that stabilizes the disease in terms of either giving oral corticosteroids, and my go-to drug in this situation would be an oral mini-pulse betamethasone therapy. In an adult, we usually start with 5 milligram on 2 consecutive days of the week, continue it till we achieve a reasonable stability, and then taper by 1 milligram every month. If the in patients who are contraindicated for use of prednisolone, then we could use the other agents like azathioprine or methotrexate, sometimes cyclosporin. I am again very attracted to use apremilast because of its, Dr. Hamzavi has talked about the pros and cons of that agent. But this may be an agent that could be used, could be tried in further studies because of a good safety profile. We are not, and that the fact that we can give that for very long periods of time, including a year. And of course, the JAK inhibitors, the tofacitinib and the ruxolitinib that have been tried for active vitiligo.
Thank you. Dr. Hamzavi, Dr. Sujay told something that he is not very convinced with VIDA. And you talked about it. So what's your take on this? That because still many dermatologists across the world are in the category of Dr. Sujay Khanpur, who are not very convinced. And talking about oral steroid, which among the three or any other is your go-to drug?
So let me handle this question deftly and respectfully. So I think that the question is, how do you assess stability? So it's very hard in clinical trials to assess stability based upon counting up new lesions. You need 2 data points. You need images. So we use 3 stigmata first to assess stability. So number 1, trichrome, confetti, and then kevnerization. Kevnerization both A and B. So kevnerization with actual trauma, the linear lesions, and then kevnerization on truncal sites in the underwear, in the straps of the clothing that would trigger that. If you have those 3 elements, you measure CCXL 9 and 10 levels in blister fluid, John and Amit had been able to show that that correlates to instability at a molecular level, and that's what we've also seen. We will look for confetti-like lesions to improve. My preferred agent is dexamethasone on the weekend, similar to the description that Dr. Kanpur had discussed. And again, I learned that from the Indian community. Dr. Ketan, I've read all their papers. And in fact, when I was in India, I found a vitiligo book in a bazaar one day, and I've been using that for many years. But at the same time, those measures should improve. Lastly, if you are comfortable with ImageJ or other software, one of the best ways to measure stability is to actually photograph a target lesion and watch over that. Is the V-score helpful? I'm not sure. I think those criteria, those stigmata, along with the patient-reported outcomes, is probably a better measure of stability and something you can document photographically with one data point as a starting point.
Okay. I'll start taking some audience questions also. Dr. Arun Agarwala from Guwahati is asking, one agent which stops progress of disease. Can we just name one agent? Yes, Dr. Ketan, sir. Dr. Ketan? I guess we've lost.
Can you hear me?
Yes, sir. Yes, sir. Yes, sir.
Yeah. So if it is progressive disease, then it is definitely oral mini pulse. I will just add one important point. We have recently done a study on azathioprine. Now, slight modified regimen that you start with oral mini pulse, give it for about 6 months or so, add azathioprine, and once you are tapering oral mini pulse, azathioprine will work 3 months or so overlap, and then you start tapering oral mini pulse, and then maintain on azathioprine. So this regimen may work better than just oral mini pulse for a very long period, because you have to minimize the side effects.
Okay. Dr. Rashmi, you take care of childhood vitiligo, so you don't have any second thoughts about giving azathioprine and oral mini pulse in patients who are having rapidly progressive or slow progressive diseases?
Actually, Rohit, I don't just have second thoughts, I even have third thoughts, because reason is that I don't, given the choice, I wouldn't like to really give it. But something, I've seen that at the end of the day, the only thing that works is the mini pulse somewhere. So the idea is that you can't give it for long. So give that, and what I do simultaneously, if I have to look for another agent, I used to add methotrexate. And then what I would do is, within 3 to 6 months, we try to stop the mini pulse and we go over to the methotrexate and keep it on, and then switch over to another agent. One thing I learned, from some of my seniors here was that, antioxidants, although we talk about them, is something that could be, an add-on. Polypodium leucotomus or some antioxidant.
We'll come to that.
So you could add to that. Yeah.
Okay. Talking about immunosuppressants versus immunomodulators, a lot has been said about levamisole and has been used. Dr. Hamzavi, any personal experience about levamisole or minocycline?
Minocycline is being used in our department, mild to moderate effect, but against the measures of efficacy have been hard to assess. The other agents I don't have experience with.
Okay. Dr. Kanpur, sir?
Yeah, so initially we used to use levamisole a lot of 150 milligram on 2 consecutive days in a week for slow spreading vitiligo, and we initially believed that it works. And then we undertook this trial wherein we used levamisole plus corticosteroid versus a placebo with corticosteroid in patients with slowly spreading vitiligo that got published in BJD in 2005 with Dr. Ramam and myself as the 2 authors. And we recognized that it reduces the activity of the disease at each point. So the proportion of patients who are not showing any activity goes down at each month, but it is not significant. So what we were believing earlier as levamisole being a great agent in slowly spreading vitiligo as an immunomodulator probably is not working. It's possible that it's the self-limiting nature of the disease, of it being an autoimmune, that is working more to contain the disease rather than levamisole by itself. Again, minocycline, there are very few studies, the use of 100 milligram per day of minocycline. In fact, some people have tried to compare it with oral mini pulse therapy, dexamethasone, and have found comparable results. But again, minocycline needs to be worked more on to assess whether it is of any utility in active vitiligo.
Thank you. Dr. Ketan sir, Dr. Rajesh Buddhadev from Surat is asking, do we have a predefined criteria to stabilize disease, whom we can start with oral mini pulse and then go on to azathioprine? Please enlighten.
Yeah, so as Dr. Sujay has already said, can you listen and hear to me?
Yes, yes, sir.
Yes, yes, we can.
Yeah, so as Dr. Sujay has already pointed out, in our department, we work on it is arbitrary, but it is by experience that we take history of last 3 months and somebody developing about 15 new lesions in last 3 months or 5 new lesions in last 1 month, then we consider it progressive and then we put on OMP. But if it is less than that, then we may consider not using immunosuppressant, but we have to follow because the person who is not developing several lesions this month may develop more lesions next month. Azathioprine I usually add after 6 months. We have done a 2-arm study and we found that it works, but nothing like OMP. So azathioprine for a maintenance long term is a much better agent, and then you can taper off OMP also. So not an OMP, if you are using less than 6 months, that is not doing justice, because the purpose of giving mini pulse form is you have to use a little longer. Otherwise, you can use daily also. If you have to use for 2-3 weeks, then you can use whatever you want to use. So that's how I use.
Dr. Hamzavi, when it comes to oral Sorolens, which among the list is your go-to drug, and what's your experience with the ones you have used? Why one is better off than other?
Well, we can only legally obtain the 8-methoxysorolin in the United States. So 8-MOP is the only one I have experience with. I will use it topically in rapidly depigmented aqueous lesions in children especially. And I use it systemically only if narrowband fails. In fact, I have just one comment. In all of our oral suppression agents, we always will use narrowband with it. So I just want to emphasize that we do 2 therapies, not just one, even with the systemic agents.
Of course, we do also. Yes, sir.
Rohit, can I say one point on the Sorolens?
Yes, sir, please.
After narrowband came into picture, many a times you feel that perhaps PUA or PUA-SOL is not required because narrowband is one of the best therapy agents. Now, those who are taking home treatment, there you have to use UVA and particularly the solar one. So in that case, the Sorolin must continue in our list of drugs to be used frequently. Otherwise, once we drop Sorolin completely after 5 years, we will not get Sorolin in the market.
Yeah, very pertinent point. Yeah.
But it gives results also. It's not only about that we want it in the market, but it delivers also.
No. So home treatment, narrowband is superior to PUA-SOL in many ways, but home treatment, you have to have Sorolin with sunlight.
Okay. Dr. Rashmi, yes, Dr. Khan, would you want to make a point? Quick.
Yeah, just to complete about the list of Sorolins that you have mentioned and their advantages and disadvantages. One is that because 5-methoxysorolin is not available in India. Now, it's used a lot in the UK because it doesn't produce the side effect of nausea that the other Sorolins produce, and therefore we will have to use the light meal. So that's one advantage of 5-methoxysorolin often being used in Europe. Now 8-methoxysorolin and trimethylsorolin, both of which are available in India as neosorolin, in systemic form in vitiligo, one would prefer to use a trimethylsorolin or 4,5-8-trimethylsorolin. The reason is that the erythmogenic potential or the phototoxicity profile of trimethylsorolin is significantly less than 8-methoxysorolin. And this erythmogenic potential is reversed with topical, which means the 8-methoxysorolin as topical formulation is less erythmogenic and has lower phototoxicity as compared to trimethylsorolin, and therefore 8-MOP is what is used in topical forms more, whether it be in topical PUA-SOL or whether we use it as a bath PUA, etc., etc. So just to complete that.
Thank you. So that's the beauty of webinars, that we are having a perspective from east to west. So we have different Sorolins being used here in India, and Dr. Hamzavi, hope you will also try to follow in those who are resistant to the treatment. Coming on to the topicals in vitiligo management, topical corticosteroids are something that we used to or still use. Dr. Rashmi, does they differ as per the affected site and age, and what is your go-to topical corticosteroid when it comes to vitiligo?
I think, topicals are definitely one of the mainstay of treatment. We can't go away, with that. We have to start with that. and where topical corticosteroids are done, especially when you have, fewer lesions more, on the exposed areas, face, neck, and other areas. That is when you are going to be using topical corticosteroid. I use the, low potent ones or the moderately potent ones like mometasone, fluticasone. Those are the ones, that I'd like to use. In children, yes, again, but we have to be careful about the face. Because, then people keep applying it on their own. So you're again careful. Initially, I would start with, a topical steroid, give it for about 4 weeks or so, reassess the patient. Then I would switch over to the calcineurin inhibitor. But what I do is, I give it once a day, topical steroid, once a day, tacrolimus. That is how I go about it, and then continue for a long time with the topical tacrolimus.
Thank you. Dr. Hamzavi, I guess you are running late, and in case there is any problem or you have to catch your clinic, you can anytime tell us and leave, because I know that you have appointments from 9:40 in your country. But just before you leave, if you can tell us what's your pick on calcineurin inhibitors?
So I think, so if I can pick on 2 areas. So one is topical corticosteroids in most of the studies show efficacy that's equivalent or at least non-inferiority to the calcineurin inhibitors. But the calcineurin inhibitors have to be used twice a day to have that efficacy. In our own clinical experience, we find, similar to Dr. Sarkar's, we like to use the corticosteroids to induce a response. And if you look at some of the CCXL9 levels and the time period, it takes at least 3 months to see a significant change based upon vascular imaging over time, especially in acral locations, but even the face. Then the maintenance can go over to tacrolimus. But just like your country, in my area, these are expensive medications. So if I have a patient with a socioeconomic class that is willing to do it twice a day, I always go with the immunophilins, the calcineurin inhibitors. But if you ask about efficacy, I believe corticosteroids every other day dosing is pretty safe, low risk of topical side effects, and I could start with that. But there's a little bit of pushback, and from the safety perspective, then I'll go with the calcineurin inhibitors. But in general, I do move towards the exact description that Dr. Sarkar had at 3 months. I do not do that in the first 3 months. I use one or the other. And then lastly, again, in combination with phototherapy, because you have to have some melanocyte effect, I prefer to use tacrolimus versus topical steroids because the studies are there twice a day to show greater efficacy. And thanks for the respect to my time. I think I have another 10 minutes before banging at my door.
Okay, thank you. So another question for you, Dr. Hamzavi. Place of vimatoprost or itenoprost as topical therapy for vitiligo management. This question comes from Dr. Vibhu from Delhi.
Well, you guys are the experts. Many of you published the initial papers on this. We've had some mild success on the face, especially around the eyebrows, for the poliosis that occurs in those areas. I can't say it's dramatic. And then there are a few reports of using it post-MKTP or epidermal suspension. We've used it just anecdotally, didn't see much of a change. But do I have a lot of evidence behind my perspective? I don't. I would have to defer to the evidence from your country showing some efficacy. But these are case series. These are not randomized controlled trials. So it's an open debate.
Okay. So as I told earlier also, when it comes to vitiligo, it's Atmanirbhar Bharat. Dr. Ketan, yes. Just your quick answer as to go to topical corticosteroid when and where.
Yeah, so just one point. In my experience, fluticasone is a very good agent even on face. It has perhaps less atrophogenic effect as compared to even mometasone. So those, between topical corticosteroid and tacrolimus, topical corticosteroid on early lesions has much more beneficial effect, and on face it has much more psychological effect. So I don't hesitate using. Of course, one has to be careful, maybe 3 months or so. So my go-to topical corticosteroid is fluticasone and tacrolimus, of course.
Thank you. Dr. Rashmi, how about your take on decapeptides in vitiligo management? You use them when and where?
Yeah, see, the thing is, I have not used them extensively. Whatever little that I have used, I have not found them to be very efficacious. That was there. In between, there was a trend for using them. When we used them, I had not found it very useful personally. So that is the time when I think I stopped and went over to other drugs.
Dr. Hamzavi, you have a different viewpoint?
You know, you broke up for a second. So which drug are we talking about again?
Decapeptides.
Yeah, so again, that's an Indian local. I don't have access to it, so I just have to refer back to the literature on that.
You have access to pseudocatalysis and superoxide dismutase?
We do, and again, there was a movement towards it. We did use it with a compound pharmacy at Northwestern University. Did not have any success. But then Dr. Schallreuter, I've had patients go to Germany with some benefit, and so apparently the compound that's in Germany, which is very unstable, is more effective. And I've seen patients benefit, but in our hands, not effective.
Okay. Dr. Sujatha, pseudocatalysis and superoxide dismutase, do you use it, and do you use decapeptides for vitiligo management?
No, we don't use, but I have a take on antioxidants. You know, they are all working as an antioxidant. So we all recognize that as a pathophysiology of vitiligo, the oxidative stress has a major role to play. We also recognize that when we do biochemical tests in terms of looking at oxidative stress on conditions like vitiligo, we see that there is increased levels of oxidative stress. We do see that the oxidative free radicals are all increased. And when we give treatment, irrespective of whatever treatment we give, we see that the oxidative stress comes down. But we don't see this translating into a clinical improvement, which means if I use pseudocatalysis or superoxide dismutase per se, then as a clinical improvement, I do not see. Therefore, they, if at all, have any value, maybe as an adjunct treatment, per se, you know, for example, you may use it with phototherapy, with narrowband UVB, but per se, they don't hold too much of promise.
Okay, and what's your take on 5-fluorouracil topical?
Yeah, so again, you know, 5-fluorouracil or latanoprost and all these agents have kind of come up to be used for recalcitrant vitiligo. And they have been tried for recalcitrant vitiligo, especially on acral areas, recognizing the fact that distal extremities are not responding. And so newer molecules are being attempted to be used for these areas. And, you know, they have been used either alone, they have been used in combination with microneedling technology, with fractional carbon dioxide lasers. We had a study from our department on 5-fluorouracil being used along with microneedling in distal extremities, recalcitrant lesions over the distal extremities. You know, few lesions showed about 20% improvement. There were a lot of side effects that were seen in the patient. They did not, the patches that were below ankle and below wrist did not respond at all. So again, you know, use of 5-fluorouracil or latanoprost needs further evidence. And as of now, that confidence on these two agents, molecules, is not that much to be used for a large number of patients.
Thank you. Dr. Hamzavi, any personal experience of using 5-fluorouracil, especially the needling technique?
So we tried it on some of the acral lesions based upon Dr. Anbar's work in Egypt, and we followed that protocol and did not see much change in the acral treated lesions. So we pre-treated with 5-FU, then we post-treated with 5-FU and did not see much improvement. But again, small study, nothing significant.
Thank you. Dr. Ketan sir, how about vitamin D analogs, calcipotriol? Have you used it, and what's your take on this as a topical?
I have some experience, not much, and it is not superior to other topical agents which are freely available, not costly like topical steroid and tacrolimus. So there is no added advantage. In fact, there was once upon a time there was some enthusiasm about these agents, but perhaps they have found their place. Doesn't have much role.
And how about placental extract that was being used a lot?
When we joined dermatology long back, placental extract was a very, very important drug in vitiligo. I mean, you know that it came from Cuba and all those things happened. But now there are issues with this because they contain a lot of things. We do not know how it works. And again, it is not superior to other available topical agents.
So I guess all this list is of orphan drugs that have been used for vitiligo. Still, it's the calcineurin inhibitors and the corticosteroids that rule the vitiligo management when it comes to topicals. Your take on that, Dr. Hamzavi? Any personal experience with afamelanotide?
So obviously, systemically, and the implants, we have a fair amount of experience. I don't think it would work topically. I think you almost for sure have to use that. But again,
okay. And how about antioxidants? Which of these antioxidants you feel works in vitiligo, and what all you prescribe?
So if you don't mind, because I'm head on a second. So I'm very confident with the effect of polypodium leukotomas in reducing erythema. I'm also very confident in polypodium leukotomas reducing visible light and UV-induced pigmentation. There's also the Italian studies showing that polypodium leukotomas help stabilize and improve vitiligo by improving photoadaptive capacity, so in conjunction with phototherapy. As a monotherapy, maybe it helps with stabilization, but I don't think that's evidence behind it. I do use it, but not so much as monotherapy, mostly because I think well-done studies, because we did part of them, photobiology studies have shown a benefit on pigmentation and erythema.
How about, just last question for you for the day, vitamin C, just your take on that.
You know, Pearl Grimes, my close friend and mentor, is a fan of vitamin C. I don't know if there's enough evidence to suggest it. So I don't use it very much, but I would not discount it. But again, we have to move towards the control trials because we're at that critical mass, and India can really help us with that.
Because it is used a lot in hyperpigmentation, melasma, PIH, and for skin rejuvenation. But when it comes to vitiligo, people think that anything that is sour food or vitamin C causes more of oxidative stress and can lead to vitiligo, but still some people have been using vitamin C. Thank you, Dr. Hamzavi, for being here. I know we would have loved to have you for more time. We will continue the panel, but it was an honor to have you here with the IADVL Delhi State Branch, and Dr. Sujay Khanpur, the president of the branch, is here among the panelists also. Thank you for being here.
Thank you, Dr. Hamzavi, for sharing all your experience with us. Thank you very much.
Thank you. I really hope that you consider coming to Bangalore on December 4th to 6th in India. And namaste and dhanyavad. Bahut shukriya.
Namaste.
Thank you.
Namaste.
Yeah.
Dr. Rohit, I would like you to wind up quickly. You've got a few minutes. You could take up the live audience questions, please.
Okay. There are a lot of questions coming in, and people want to have some sort of a consensus as to what's to be used if a patient comes to us for the first time for stopping the disease. I guess Dr. Binod Ketan sir and Dr. Khanpur sir have given their take that we start with the OMP and then move on to azathioprine.
Just to add, Dr. Rohit,
yeah,
when it's extensive vitiligo and rapidly spreading vitiligo, I, in the first instance, prescribe OMP plus narrowband UVB therapy. So one is causing cessation of activity, and the other is causing both cessation of activity and good repigmentation.
Okay.
So that combination will work.
Thanks. Dr. Praveen,
can I put in a word?
Sure, Dr. Khandari sir.
Slow acting.
Switch on the video also.
Sujoy, azathioprine is very, very slow acting, So
no, I was talking about oral mini pulse therapy. I completely agree that azathioprine is slow acting. It takes 4 weeks,
OMP together, and gradually then azathioprine can take over and OMP can stop because of the side effects. But otherwise, azathioprine alone is too slow acting for it to sort of have an effect on the rapidly multiplying cell.
That brings to another question on azathioprine by Dr. Ashish Pipli from Nagpur. He's asking, azathioprine is pulse dose, say twice weekly. Is it efficacious and safe as compared to daily azathioprine? Dr. Ketan sir?
No, we have done a study with daily azathioprine, and it's a slow, as Dr. Nari has said, it takes its time out. It works. The onset of action is after, say, minimum 2 to 3 months. So I don't use pulse form azathioprine, I use daily azathioprine.
Okay. Dr. Rashmi, Dr. Praveen from Nagarkoil is asking, how do you counsel for vitiligo affected patients for marriages?
I think Dr. Praveen himself is an expert in that, I think he's done this project of, people getting married in vitiligo. So he's in a better condition to answer, but yes, it needs a lot of counseling. I usually try to call both the bride and the bridegroom. One morning I found, that the bridegroom and his entire family had come and they were waiting outside my room, that what to do. So you have to explain to them that it's like any other disease. there is a small percentage which can always be, transmitted to the offspring. But, they can even discover vitiligo later after the person is married, or even the bridegroom can get it sometimes. So that is the way I counsel. I show pictures sometimes that, vitiligo developing after marriage, or the bridegroom get it. So I ask that, is she going to leave you? So the answer is no. So that is one way that I try to counsel them, and I give them a lot of stories. How much it works, I don't know, but it does work in some cases.
Okay, just take the last question for the day. Dr. Muthu Kumaran from Coimbatore is asking, vitiligo occurs genetically. How do you counsel patients for this? Dr. Sujay Khanpur.
I like to better use the word familial and not genetic. So what I'm trying to emphasize is that it runs in families, and of course, if you have both father and mother suffering from vitiligo, there is a higher chance that the subsequent generation would have vitiligo and so on. But there have been certain genes implicated, but there is no conventional genetic predisposition in terms of an autosomal dominant and recessive. So I just say, depending upon the absence or presence of vitiligo in family members, which degree relatives has the vitiligo, the counseling is offered to the parents. In majority of the patients, the disease does not go from one generation to the other, about 90%. So it's familial, it's not genetic. So that's the message that I would like to give.
Okay, so that brings us to the end of the session. It was a very interactive, there were many questions, but because of the time constraint and Dr. Gullima, before she asked me to leave, thank you panelists for being here. And as we observe the World Vitiligo Day, hope we can be of more help to our patients when we treat them tomorrow for vitiligo. Thank you, Dr. Khanpur sir. Thank you, Dr. Rashmi ma'am. Thank you, Dr. Ketan sir. And of course, thank you to the organizer, Dr. Gullima Arora ma'am, for having us here. Thank you.
Thank you, Dr. Rohit, for that very enlightening panel. And now moving on to the next panel discussion on the surgical management of vitiligo, I would like to invite our chairpersons for the panel, Dr. R.P. Gupta sir, who is a senior consultant practicing dermatology since over 35 years. He is the director of Skinovation Laser Clinic, New Delhi. He has been the past president of the Indian Medical Association, Delhi North Zone. He was the past president of the Delhi State Branch and is the recipient of Professor Dr. K.C. Kandhari Award. He has organized several conferences and is the president of several of them too. Our next chairperson for the panel is Dr. Rishi Parashar, who does not need too much of an introduction. He is a senior consultant at Sir Gangaram Hospital, New Delhi. He was the vice president of the IADVL in 2019 and the president of the IADVL Delhi State Branch in the year 2016. He too is the recipient of Dr. Sardari Lal Memorial Award 2019. I welcome both of you, sir. Our moderator for the next session is Dr. Sumit Gupta, and we would like you to invite him to introduce the panelists. Thank you.
Thank you, Gullima. Every Sumit is not Arora, so some of them are Guptas also. So I know you are used to Arora as a surname.
Sorry about
that. It is my proud privilege to introduce Dr. Sumit Gupta, who is going to be moderating this session on surgical management of vitiligo. He is an alumnus of the prestigious Maulana Azad Medical College and did his MD under the legendary Dr. V.K. Garg. He won his Pyarelal Sharma and Bishan Devi Gold Medal for the best clinical dissertation from the University of Delhi. The dissertation, guess what, was on melanocyte transfer in vitiligo. And one thing led to the other. The next thing, he was invited because of his gold medal to the World Congress of Dermatology as a rising star scholarship to present it in the World Congress of Dermatology at Vancouver, Canada, 2015. Due to that work, see, one thing leads to another, one good karma leads to another. It will end with good karma, Dr. R.P. in the end, you'll realize. Due to that work, he was invited to participate in the research on vitiligo at University of Ghent, Belgium, under the Professor Nanja van Giel. He has given so many workshops, Indian and internationally on NCE as the non-cultured epidermal suspension. He has contributed chapters in various books on vitiligo surgery. And because of this, there are two lucky things for Dr. R.P. Gupta. One, he is the father of such an illustrious son. And because of this son, you are getting a chance to chair a session with me, Dr. R.P. Gupta. Sumit, the stage is all yours.
Very, I'm grateful for that kind introduction. Just a moment. Yes, I hope I am audible. Okay. Thank you very much, Dr. Rishi, sir. A mentor, if I may call a friend, and a guiding light always for myself. And I also thank Dr. Gulhima and Dr. Sujay Khanpur sir for giving me this honor to moderate this session with such stalwarts of vitiligo surgery, whom I have learned from the starting day of my dermatology career. So let me start by sharing my screen. All right. So I have an illustrious panel with Dr. Mukesh Girdhar sir. He's a senior pillar of IADVIL Delhi State Branch and one of the pioneering people who introduced non-cultured epidermal cell suspension in the country. Welcome, sir. Dr. Sumesh Gupta sir, who's a professor of dermatology at All India Institute of Medical Sciences, and we dare say father of our generation of modern dermatosurgery in India, and has so many innovations under his belt. Dr. Neeti Khungar ma'am, who is the professor of dermatology at Safdarjung Hospital and Vardhan Mahavir Medical College. She again has taught us and has been the leading light in the procedural dermatology world. Dr. Sandeep Arora sir, he is the senior advisor, group captain, and head of the Department of Dermatology at Command Hospital, Bengaluru, Karnataka. We are missing him so much. He's been away from Delhi for almost 4 or 5 years now. And he has also taught us so many procedures. And Dr. Munish Paul sir, he's a senior consultant dermatologist and an old hand at vitiligo surgeries. We all have seen him and learned from him over the years. So first of all, I'll like to begin with the counseling part. So we've heard about counseling with regards to increasing confidence, prognosis and stuff. But with regards to surgery, it's very important because whenever we are touching the patient or let's say cutting the patient, the expectation of the patient is much higher. So what is possible with surgery? If someone could just summarize that, I would like to take that question to Dr. Sumesh Gupta sir.
Okay, thank you very much for starting this discussion on this very important but often neglected topic. So, just a few minutes ago, I was in another discussion, was discussing this, that when the patient comes, often they come with a perception that they are undergoing surgery for the cure of their condition, which is exactly not the case. So we have to tell them that it is just a cosmetic cover. It doesn't affect the course of the disease. It doesn't affect the future chances of recurrence of the disease elsewhere or in the surgically treated area. And even with the best perfection and in the best hands, like Sumit's hands, there is a chance that in spite of 80% repigmentation, 90% repigmentation, so for 75 to 80% repigmentation. But for patient, it is still a reason for gross dissatisfaction because even the slightest of the depigmentation remain post-surgery lead to a lot of
So we are losing
every chance that you don't get documentation in the form of treatment or phototherapy to complete.
Hello.
Yes. Yeah.
Yes. So, okay. So let's say this kind of patient who has a segmental vitiligo, and he comes into our clinic and has some other disease, probably he's come for acne, and he's not asking anything about segmental vitiligo. Probably he's told that this thing has no cure, and you want to counsel him, and you're reaching to sort of do a surgery for him. Would you at all talk to him about it and counsel him, because he may have been counseled that this has no cure and he is roaming like that?
So, with whom you are asking, Sumit?
Sir, I'm asking you, sir.
Okay. So, see, I would not touch it. I would not ask him to get it done unless the patient himself tells that. There is a possibility that patient has accepted the reality and patient has accepted it in the life, and patient just want to move on. It also depends on the age of the patient, and if patient says patient is in a younger age, marriageable age, or in an age of where the employment is an issue, then perhaps I can touch upon it as a holding a sympathetic hand, and then I can ask. But if a patient is an older patient and has passed that age when the stigma hurts a lot, then possibly I will not even mention it in the discussion.
What's your take on this, Dr. Munish Paul, sir? Would you like to counsel him and proactively tell him that this can be treated and this is an option which you can carry it, or you can just get it removed?
I think if it's a case of, a segmental vitiligo, I would agree with Dr. Sumesh that we should not proactively try to sell a procedure or, tell the patient. But again, the flip side is, that the processes are better, the results are much better, and considering specifically what you said, it's a segmental vitiligo, which we know overall has a good prognosis. The chances of repigmentation is very good, and the chances of it staying repigmented is pretty good. Actually, the procedure might change his life. This procedure can change his entire life. One process, 3 hours of process, this is what I tell my patients, can change a patient's life. So a very subtle, very sensitively, with a lot of compassion, you can just drop a thought, okay, it can be treated well, and just leave it at that and let the patient come.
Okay.
Yeah, Sumit, can I add something?
Please.
Yeah, I would ask him or any other patient, what is your motivation for the surgery? That's the first thing I ask them. Because sometimes, a patient may have a lot more motivations which and expectations which you may not be able to fulfill. And this happens very much in patients, even who are married and then get vitiligo when they feel that there's a problem with that. I tell them that, okay, this will make a difference, but I think you should not put so much stress on just because if your disease gets better or you look better that everything will change. They feel that if my vitiligo improves, whether it's medically or surgically, everything in life is going to be normal. But I think there are a lot of other social factors also, and the motivation of the patient becomes very important, and we have to tackle that first. And then, of course, what Somesh said, that it may not be complete, you can't alter the course of the disease, but I feel seeing it from the patient's point of view and trying to tackle that is very important. And as regards this patient, I would very quietly ask him, are you bothered with this? If he says no, then it's fine. But sometimes patients are too shy to ask, or they don't have the knowledge. And then you could probably offer a treatment. The other thing is I'm very, very fond of camouflage also. And I find that just camouflaging regions, like I had some college students who have acral vitiligo or who have, on the face, if they just use camouflage and they go on their daily activities, they are much more happy, their quality of life increases. So I think I offer that even in the beginning also, that till the time it takes for you to improve, you can use camouflage, and many of the patients don't even know about it. So I think we should not underestimate the power of camouflage.
Sumit, if I may add.
Yes, sir, please.
You brought out a very valid point that this patient came for something else. it's not uncommon to see this in practice. Usually these individuals have already gone through some form of treatment, are not very happy, and that's why he's not brought it out in the first sitting itself. Most of these people, when they come back in the second or the third session for something else, then they quietly ask you, is there something else for this also? I think it's probably at that stage that you can broach the topic rather than doing it straight away in the first session.
Okay. Very good words of wisdom. So coming on to a more commoner scenario, we get these patients who have this almost like a glove or and stocking sort of vitiligo, and they've come from far away with high hopes of surgery that is going to erase it. How do you counsel them against it without being too harsh and make them almost suicidal at some time? Dr. Mukesh, sir.
All right. So there are very conflicting photos which you have put there. The first one is a patient who is having vitiligo on the face, is not even seeking treatment for that. And I think in all fairness, in my consultation, I will not mention about that disease. Just because I know to operate on this patient doesn't mean that the patient has come to me for some other problem, and I should mention that. The other patient is the other contrast where I should not operate. She is asking for treatment and we should not be operating. In fact, even treating this patient medically also, we know what the difficulties are, what the prognosis is, and we know it's going to be, even if we are treating this patient, we may improve some pigmentation, but that will not make any difference to her life. So, but as you said, this consultation can be very devastating for the patient if you get very negative outcome. So we have to treat this patient with the medication available. Maybe put her, looking at the hands, I can say that this is a aged lady. So one has to see her priorities. Maybe her children are in the marriageable age group, and that is why she has come to us to take treatment for this. Because in our country, there is a lot of stigma, even if a parent is having vitiligo. So we will be counseling the patient. We will be starting some treatment. If possible, maybe narrowband UVB phototherapy and nothing else. If the patient cannot come to my clinic for the narrowband UVB, maybe I will put her on Uvasol. But I will not say in the first visit that your disease is not curable. So there is an issue there.
Okay. Yes, sir. Dr. Sandeep, sir. Kindly unmute yourself.
Yeah. If I may add to that, a lot of these patients come to us for a finality.
Yes, sir.
At some point of time, it may not be the first, when they first visit you, but at some point in time, they're looking for hope that your treatment is going to be effective in them despite whatever they've gone through in the past. More often than not, when you say this, I'm talking from the surgical point of view, to an extent it can be extrapolated to a medical management also. The moment you tell them, please don't go ahead for treatment, it is not going to work, most of them are thankful for a closure. That we have gone through a lot of it, it is not going to work, or it's going to work to an extent which the doctor is now describing. They don't expect a miracle any further. So at some point in time, we have to draw a line and say, try this. If it works, excellent. Otherwise, don't go ahead. Most of our patients who do hear this and are basically waiting for a closure are very happy with it. Of course, there are a few who will say, try something else, and we do have backups for them.
Okay. So what about outstation patients? Dr. Munish, sir, I'm sure you get a lot of calls from far places that, okay, we would come only if we have to do surgery. So how do you counsel them? Okay, there may be patients who have doubtful stability. Some are obvious, like segmental vitiligo. How do you go about them?
So, Dr. Sumit, if we have a patient from outstation, who are seeking a treatment, so obviously the first and foremost question is, you have to dig into the patient and ask clearly, when was the last time you saw a new white patch? You have to establish stability over the phone, over the online, or whatever, and there are no two ways about it. So you have to establish stability. That is the most important thing, as much as you can from the history perspective. Second point is, obviously, online consultations are now kind of legal now. That has helping us so much, especially in dermatology, I would say. We can get photographs, and as we know, if a patient has stable vitiligo, the margins will be more sharp. There would be perifollicular pigmentation. It's not hazy, it's not a trichrome type of a vitiligo. And so given the history that the patient is stable, and clinically, by the look of the photographs, you feel the patient is again stable, you can consider. Then the third point is, obviously, in an outstation patient is to see the extent of the lesion. This is a very common problem. Now patient will expect, okay, I have hand, feet and leg and this, they might have 400 centimeter or 500 centimeter square of area to be operated, and they think, okay, they'll come, get it done and go back, but we as surgeons, we know that okay, there's a limitation to how much we can do. So we can counsel the patient about this. Then it has to be, it becomes a quite detailed counseling, I feel, even online. So roughly you give them some information, tell them, okay, speaking, this is my website, you can go on this, get some details, go on Google, search for it, this is the process that we are planning to look for, and categorically in your case, tailor-made, this is the plan. But finally, once you come over, we will sit down, we will discuss what are the options, what are the chances of success, what are the chances of recurrence, probably, that's how we would go out with the outstation patients.
Thank you, sir. Thank you for such nice illustration of how you tackle outstation patients. And now coming on to the burning question of stability. Do we have a perfect definition or even understanding of this term, Dr. Sumit, sir?
Yeah, Sumit, forget about the perfect stability. We are not even close to a modest definition of stability, because stability is very elusive. But one thing I want to tell is that stability and disease activity and success to a transplant procedure, we can explain to the patient in statistical terms. In statistical terms mean we know that, and that we have published it earlier in the British of Dermatology, that longer the duration of stability, better is the repigmentation post-transplantation. There is a linear relation. So if the stability is 1 year, still some patients will not get repigmentation and some patients will get insufficient repigmentation. So if the longer disease stability is there, patient can be assured of the success, that there is a very good chance of your patch being getting repigmentation completely. So generally we take the 1 year definition as the IADVL definition, but we have to supplement it with many things. For example, we have to see the definition of the patch. If it is a well-defined patch, then it is a good sign. If it is an ill-defined patch or margin is giving up, then it's a bad sign. If there is punctate depigmentation, then it's a bad sign. If there is a hyperpigmented margin encroaching the depigmented margin, it's a good sign. If it is the hypopigmented margin encroaching the pigmented area, then it's a bad sign. Then we can supplement it with the Woods lamp examination with dermoscopy. Dermoscopy is still not so verified in large data supplement. So I'm still not sure how dermoscopy will help, but gut feeling says that it might help. So we sometimes patient, for the want of surgery, gives us a false history. So we have to keep that in mind. We have seen multiple number of times that patient comes and says that stable, I have a stable disease, but we have to ensure, and one simple way to ensure is that if patient has a photograph 6 months before the presentation, and then we compare with the past photograph, if there is some loss of pigmented island within the vitiligo patch, it's a bad sign. If there is some repigmentation from the margin as compared to the previous photograph, then it's a good sign. So these are the things, and stability, rather than a very clear definition of 1 year inactivity of disease and absence of Koebner phenomena, it is too simplistic in today's era. So this is what my take on stability.
Thank you, sir. Mukesh, sir, we have this sort of debate always. Can we induce stability which is actually stable? As in, we do try our agents like immunosuppressives and stuff and try and induce. But is it actually stable, or it is only for the time being we are giving the treatment?
So the first question is why we need to induce stability. There is a particular patient who is in the dire need of surgery, a marriageable boy or a girl whose date of the marriage is decided. There is a localized disease, but we see by our parameters, looking at the patches are unstable, or it doesn't fit into, a long enough stability, say 1 year. So suppose somebody has a patch which showed stability maybe since past 6 months only, or you are not convinced about the stability, then there is a question of giving an immunosuppressive treatment to suppress the disease process, to make it stable so that when you operate, at that time, the disease does not get activated. So for me, inducing the stability would be in very, very unusual circumstances. I just don't like to do that. But having said that, one can induce stability to some extent by giving oral steroids. OMP is the preferred method of giving steroids, but here in this case, perhaps somebody would need to give for a month daily course of steroid or alternate day steroid. Or alternatively, now we are using cyclosporin to induce stability. Low dose cyclosporin, 3 milligram per kg per day, would be perhaps a better choice than giving steroid to induce stability. So you may start it about a month before doing the surgery, but then you will have to go on giving it till you are able to see, complete pigmentation, and still you taper it. Don't stop it abruptly, because if you lose whatever pigmentation has been achieved, it doesn't make any sense to then, subjecting the patient to all this process.
Yes, Dr. Manish, sir.
So Dr. Mukesh, you raised a very interesting point. You said you prefer cyclosporin over steroid in inducing stability pre, intra-op and post-op. Why do you say so, sir?
No, I did not say I prefer. That these days we have started using more of cyclosporin. So I have a lot of experience of using steroid to induce stability. Cyclosporin is just a new kit so far as the vitiligo stability is concerned. As such, we don't have much of literature on cyclosporin in vitiligo.
So if we don't want to use a steroid, so we can use cyclosporin.
That's right. That's right. Yes, sir.
Dr. Neeti, ma'am, can we predictability plan in some type of patients? Okay, we are going to do your surgery after 6 months from now. Let's stabilize until then, and let's plan a date. And can we do that, or it's just wait and watch type of game?
I don't think so. You can do it. In fact, I think the whole discussion of stability is very unstable. I've had patients who have been stable for 10 years. I did the surgery, and within a month they got lesions. And I've had patients who were unstable, and they said do a small area and nothing happened. So I think this whole discussion is very unstable and very unpredictable. We can't really say, and as Somesh said, the definitions, we still don't have much because we don't still understand so much about vitiligo. So,
Dr. Sandeep sir, do you do surgery under the cover of immunosuppression? What protocols do you follow, if at all?
Okay, so it is not the norm, definitely, as has been brought out by the other panelists. So the reason why I guess we are debating this is a scenario where we seriously need to do surgery at an earlier date, and rather than wait for 1 year. So if we were to do this, in just a few cases, what we've done is we've put them on a daily dose of prednisolone, or followed up with a tapering dose over the next 2 months, overlapped with azathioprine, and continued on that. An ideal situation for us would be at least 6 months of immunosuppression. The reason, patient by now knows that they are getting treated for vitiligo and being prepped for surgery. So at the end of 6 months, we take a second call. Out of the, I think we did 3 or 4 cases, 3 patients never wanted surgery at the end of it because they realized the stability had not been reached. In one we did, they maintained, they had no new patch till 1 year and then developed a new patch. So as Dr. Neeti brought out, Stability, we know as much about stability as we know about the disease itself. So I would possibly postpone surgery and explain this to the patient with these examples.
Can I just make one? Sometimes I'm giving intralesional steroid at the edges and the periphery, just because I feel trauma of the dermabrasion, or whatever way you choose, whether you do the CO2 laser, it does induce trauma, and that can cause the patch to become unstable or make the disease unstable. So what I'm doing is, after a week, 10 days, when we remove the dressing, I am doing giving intralesional steroid 0.5 milligram per ml at the edges. I don't know how many would agree, but we have been doing it since the last 5 to 6 months, and I feel probably it may make a difference, though I don't have my results tabulated so far.
We have been doing that, but for limited patches, yes. We have been
just at the edges, not at the entire patch.
Dr. Paul?
See, I'm going to bring this up in a different way. I actually disagree with all my panelists now. Okay, so I agree with what Dr. Neeti said, that the whole concept is unstable. So I don't think so it is like that. We understand that the best thing we understand about vitiligo is that it is unpredictable. Point taken. Okay, we all know dealing with it. Okay, so we agree on that. So in this situation of unpredictability, how do I improve my chances of surgery? Okay, now see, understand, till now, if you're doing medical treatment, you're giving a patient a topical steroid, tacrolimus, phototherapy, it's non-invasive. Okay, now you're looking at a surgical process which is invasive. You're going to take a skin graft, whatever you wish to, and then plant it. And obviously, a skin grafting or a surgical process would have some end in mind. Means if a patient is going for a surgery, grossly it is marriage, job, or something. So there's something very substantial goal for him or her to attain. That's why he or she is, willing to take that step, or the family is going ahead with a step. So if we have to do a surgery, we have to improve the chances of the success of the surgery. And we cannot say that if a patient, as Dr. Sandeep rightly mentioned, patient has been on some medicine, to control the activity, then those patients would do much better. The prognosis would be much better on those patients. So why do we say we don't know anything about this? No, we know a lot. So a patient has to be put on medicine. They have to be hospitalized before the procedure, during the procedure. You improve their chances. It's like we used to discuss acne scar treatment. So we say, should we do it on isotretinoin or not? Now we know patient should be on isotretinoin to improve your results. If the patient is on isotretinoin, you will not get collagen formation. So I say, you want to operate a patient with vitiligo, why not stabilize him? What do you have against stabilizing him? I mean, he has a target in mind. So help him achieve the target. You need to boost it up. So if you are helping him medically, give it enough time and then operate him, I think results will be much better. I mean, the chances of pigmentation will be much better.
Yeah, Munish, the only question was a time period. That's what I just meant. You can't predict a time period. That's all. Of course, otherwise we wouldn't be operating our patients and wouldn't be getting good results. It's just that you can't talk about the time period.
Dr. Sumit, you'll have to hurry up, please. We've got very few minutes left.
I think none of us wanted to operate upon an unstable patient. We all said that unstable patient should not be operated. We talked about the exceptional situation when the patient is in a hurry, there is no time with the patient, and that scenario what is to be offered. Otherwise, nobody wants to operate upon a patient who is unstable.
Panel discussion on stability, just one day, just sharing one case. I had this patient, like Dr. Neeti said, who had been on narrowband UV for almost around off and on for about 2 years, and he was completely stable, just had repigmented most of his patches, just had this patch on his elbow and one on his ankle. And we did a non-cultured epidermal cell suspension under the cover of oral mini pulse, started 1 month before and ended 1 month after the surgery. And he pigmented his elbow patch quite well, but the ankle patch, he started pigmenting, not as well as we would have liked, then again lost pigmentation, and when he came at 10 weeks, he had lost the pigmentation he had gained at 6 weeks. And at that time, I noticed his donor area had also started depigmenting. And at that time, I started him on OMP, and after 4 weeks, he again started a little bit of repigmentation at both the sides. So there are this shows there is also something known as local and global stability, and also we don't know how stable a stable patient apparently is. So moving on to other topics. Now we all know we cannot go finish this panel without this mandatory topic of tissue versus cellular methods. So most of us in this panel, probably almost all of us, are now preferring cellular methods, and we know the advantages and disadvantages. Are there any site-specific preference for any tissue methods, tissue-based methods? Dr. Neeti, ma'am.
One thing is, apart from site, is if the patient wants quick pigmentations, the cellular suspensions do take time. They can take right from 6 weeks to 3 to 4 months. So if the patient doesn't have much time, then I would prefer a thin split thickness skin graft if the patient wants quicker results. And otherwise, on the face, definitely the cellular are much better. Except sometimes, again, if the patient wants quick results in the lips, you can do a suction blister grafting. I think punch grafting has no role, except if you just want it as a filler in some places where there are very small lesions left. Maybe you could do a punch grafting. But of course, the cellular is much better.
Dr. Sandeep sir, would you use something like a punch graft or a suction blister graft at certain important sites?
Suction blister, I would probably still prefer for the lip. Of course, cellular is, we have been doing cellular also there. As mentioned, I would, the peripheral hypopigmentation which is left over sometimes with or depigmentation which is left after cellular transfer, I could target if one isolated patch is left rather than go through the whole process of the, preparing the cellular method and taking so much time. I could just take out a few punches and put there. That's where I would be preferring. We have been doing it on the areola earlier, but the results are much better now with the cellular method.
Okay. So the cellular method that most of us use is somewhat like this. We take the graft, we trypsinize it, do the cell separation, then prepare the site and transfer it. Now there have been a plethora of modifications. Most of them have been suggested by our honorable panelist, Dr. Somesh Gupta sir. He's been the innovator-in-chief in vitiligo surgeries. And now, how do we take what modification we have to adopt in our practice? How would you decide that? Dr. Somesh sir, I would begin this question with you.
Okay, modification should have two important things. One, that it should either improve the outcome or it should make it easier, simpler. So if it achieves both the goals, then it is successful. Now, the issue with NCAS is that it is already so simplified that any alternative to currently practiced method of non-cultured epidermal cell suspension has a very great challenge to improve it further. All we can do is, in spite of, we can reduce the time, we can reduce the need of equipments, we can reduce the need of reagents. For example, now we can make it safer. For example, now we are using, instead of phosphate buffer saline, everybody is using Ringer's lactate because it is permitted to use in the patient and it is easily available in the hospital and it is very cheap. So there are many new kits which have been introduced, but I would say that all those make the procedure very expensive. So if any procedure, any modification, if it fulfills these 2-3 criteria, it makes it simple, it makes it more effective, or it makes it cheaper, then it is worthwhile.
Okay. Mukesh sir, would you like to weigh in on this as well?
Okay. My thoughts are very simple on this. See, once you have perfected a particular technique and it is working for your patients, to save on the money, I don't think I will want to do that. So far as simplification of the method is concerned, I think for me the process is simple and it is giving results to me. So I don't want to change the winning combination, winning formula, unless there is a situation where you don't have a graft or something. I don't find any reason why should you not have a graft.
Dr. Sumit, you have to wind up, please.
I'm just doing that. I hope you can give us the liberty of a few more minutes because this is the last session. So, okay, moving on to the next difficult sites. Lips, Dr. Neeti ma'am, what method do you prefer? How do you dermabrade? How do you stabilize and how do you dress?
Yeah, for lip vitiligo, what I classify in my mind is there are 4 types of lesions which can occur. One is the patchy type, which is not uniform. And according to me, most of these cases are post-herpetic leukoderma. So if you have any patient who comes with depigmented lesions, he may have vitiligo, he or she may have vitiligo elsewhere also. But here, if the lesions are patchy, they are small and not together, then I would always ask for a history of of herpes, and I would give acyclovir before and even after the surgery. Then you have focal lesions. For very small focal lesions, I prefer either a suction blister graft or a very thin split thickness graft. It's much faster as compared to a suction blister. But if the whole lip is involved, then I would prefer either NCS or even a split thickness skin grafting. That is the third type. And the fourth is a mucosal when it is more inside. Again, here I would prefer either NCS or I would prefer a very thin split thickness graft. And if it is inside the mucosal area, I like to give a small suture. You just invert the lip like this and give a small suture, keep it for a week. And after a week, when you remove the dressing, you remove the suture.
All right. Thank you, ma'am. What about eyelids? Dr. Mukesh sir, again, would you like to give us certain pointers? How do you prepare the eyelid area?
Yeah, so eyelid surgery is something very important that you need to use eye shield before you operate upon the eyelid, because you can't, you don't want any damage to the cornea. So once you have put the eye shield there, normally I use topical anesthesia, and unless I see the patient is, anxious type, then I will give, 1% xylocaine also there. So that gives some tumid anesthesia also, so that way you can abrade it better. And everything is as usual, except that at the time of dressing, after putting the dry collagen sheet, I leave it just like that. I don't cover it with any dressing after that. And the dry collagen finally dries out and falls off.
How many days?
So once I have applied it, and I'm not going to remove it. So in a week or 10 days time, it's going to come off anyway.
All right. Okay.
Can I make one addition?
Yes, ma'am.
Yeah, I don't do it with an eye shield. I think you just need to give a local anesthesia to make it a little tumid. And the whole trick is how you do the dermabrasion. What you do is, one is you take a pear-shaped diamond face. It should be pear-shaped, and you start doing it perpendicularly to the tip, so that as it moves, you don't do it horizontally, you do it vertically, like this. So when you go like this, there is no chance of it going inside the eye. And do a very light touch, and I've never used an eye shield, and I've never had any problems so far. The only thing what I do is I put Neosporin eye ointment before the surgery as well as after the surgery. And then I do a dressing for about a week.
Dr. Sandeep sir, would you prefer using a laser source for dermabrasion in this sort of?
In this case, we usually go ahead and under the corneal shield, we do a ablative CO2 laser, and it works quite well. The basic idea being, with what we have faced with the motorized dermabrader is the chance of splitting the upper eyelid. So of course, with the way the direction which Dr. Neeti brought out is very safe. But if you were to angulate the dermabrader bar, it splits the upper eyelid, and then we have a complication at hand. So normal ablative CO2 laser, I would probably prefer here.
Okay. All right. So now moving on to the next area, Dr. Munish Paul sir. Genitalia or the areola, you've had plenty of experience and showed us how beautifully you've treated them before. Could you just take us through how you do it?
Areola is pretty similar to what we do other areas, Dr. Sumit, and I think, since there's always something known as the recipient dominance, so the areola is normally hyperpigmented, so even if the amount of cells you're putting is less or certain areas are skipped out, they will take up pigmentation good. You should put small bits of collagen. That is my suggestion, because again, we know that these muscles can contract, even the areola can contract, depending on the heat and the temperature, right? So if you put small bits of collagen, it can move with the skin, rather than putting one big collagen sheet, which will not move. That is especially true if you're doing the genitalia also, especially if you're doing the male genitalia, the penile area, or even the scrotum area. So you have to put small, I use the word pixel collagen, so just put small bits of collagen everywhere, And as Dr. Neeti rightly mentioned, you have to have a pear-shaped burr, and a high-quality burr, because it's more easy to use. It's like you can use, just rub it like a pen, but if you're using bigger wheels, they're more difficult to control, as Dr. Sandeep was mentioning, you have a difficulty in damaging the eye. And I think that's it.
Sir, Dr. Sandeep sir again, I'm sure you must be getting a lot of firearm injuries or even burns for that matter. They also develop leukoderma and they are also similarly stigmatized as vitiligo patients. I'm sure Dr. Neeti also does a lot of, gets a lot of burn patients because of this thing is a major center for that. So have you tried any of the cellular methods for post-burn leukoderma? Dr. Sandeep sir first.
As a routine, the cellular methods work very well. The only thing is we wait a little while because quite a few of them repigment on their own to a large extent. So once we have followed them up for a reasonable amount of time, and which is around 6 months, here instead of for preparing the recipient side, we as a convention use an ablative CO2.
Okay.
Because it is really tough dermabrading and it's very irregular. The surface is very irregular to keep a regular plane with the dermabrader. Manual dermabrader is tough. Electrical dermabrader, the butt tends to go up and down and it can't maintain one plane. So you may have a deeper plane. So compared to that, CO2 laser we found is much better. Combined with the cellular transfer method, the results are very good.
Dr. Sumit, you'll have to wind up, please.
This is the last slide. This is the last slide.
All right.
Can I just add one thing?
Yes,
Sumit, in most of these post-burn, I found that doing nanofat grafting, just the nanofat grafting does give pigmentation also.
Okay.
So I found it also improves the scar quality. Okay. So now I've been doing for the post-burn scars, I have been doing just nanofat grafting, and the pigmentation also improves. So maybe we may not require...
this is something that what Dr. Sumesh has also done with mesenchymal cells.
Yeah.
Dr. Neeti, can I have a...
Yes.
Yeah.
That's very interesting. I mean, can you just elaborate? That's beautiful what you just mentioned. I mean, these are patients who are post-burn depigmented.
Yeah.
Wanted fat in that and they...
Yeah, the pigmentation also came back.
Wow. Awesome. I mean,
yeah.
It's to do with what Dr. Devendra has also been talking about dermal stem cells.
Yes, so, that's what I've been telling you also.
I need to get there. Thanks, ma'am.
Dr. Sumesh, one word about relapse. What type of impact with relapse? And the surgery repigmentation relapse?
Thank you, Sumit, for last question. And this is a very important question. What type of patients come back with relapse? So generally, we have seen more relapse in the acral area as compared to other areas. The lip vitiligo generally stays. Even in acrofacial vitiligo, the pigment stays. And luckily, fortunately, what we have observed that although some patients, they do come with the loss of surgically achieved repigmentation, so we now put them for indefinite topical or phototherapy related skin directed maintenance therapy. Now there are good studies on medically achieved repigmentation maintained with tacrolimus, topical tacrolimus. So to start with, we keep on giving on a daily basis. then alternate day basis, then weekend basis if sufficient period has lapsed. But there is no guarantee that with the pigment will not be lost in due course in acral areas. So second thing is that in some patients we have found that the surgically achieved repigmentation stays, and the surrounding skin or rest of the body patient gets new patches. So this is what we call the donor dominance. Here the donor site autoimmunity persists even with the recipient side, because generally we don't get many patches on the thigh unless it is an extensive vitiligo. So it is very difficult to predict, but one thing that is acral area, bony prominences, fingertips, if you have achieved successfully the repigmentation, the patient may lose pigment in due course. So we have to counsel the patient about this.
Thank you, sir. And just give it this slide about phototherapy protocols. I guess most of us prefer narrowband UV or targeted, if possible. Otherwise, that's all after epidermis forms and depigmentation. Dr. Munish, sir, you would like to take that?
Okay. Even though I operate a lot, I think of late and since last few years, my amount of depigmentation patient has increased tremendously. I have started actually operating less. So I mean that's a very big learning even for me. Even I used to operate a lot, but my threshold for depigmentation has dropped. If I see a patient who's very unstable, very bad, and not even like 50%, even 30%, warms, you kind of get a feel like, oh, this patient, you may able to achieve repigmentation, but you can't really hold it for a very, very long. That rather than putting the patient on phototherapy, immunosuppressives, and going on for a long time, such patients are better to have one uniform color with depigmentation. And my choice is, I start with MBH first and Q-switch Nd:YAG laser 532 nanometer for the face. So that is the plan. So for the face, I deal with the 532 straight away. And for the rest of the body, we say, okay, start using 20% MBH, and go about it.
Okay. Okay, so with that, we conclude our enlightening panel discussion. I tried to ask certain different type of questions, not focus too much on procedural details because most of the questions are based on that. So with that, we thank the organizers for having us, and I would also like to look forward to everyone's valuable support for these dates on Dermacon 2023. Stay safe, stay healthy, and thank you.
Thank you for having us here.
Thank you.
Thank you. Can I conclude the session?
Yes, sir, please.
Thank you.
Thank you, Dr. Sumit, for conducting this session very nicely, and all the panelists for their valuable inputs. And I thank the organizers for inviting us to chair the session.
Thank you, sir. Thank you, panelists. And that was a very enlightening session. Dr. Sumit, thank you for that. Moving on now, it is my proud privilege to deliver the vote of thanks. And we are grateful to each and every one of you for having participated in this CME. Thank you, Minister Saab, for coming, for kindly agreeing to come and give us your part of the story and making us believe that just because you are different doesn't mean that you cannot make a difference. Our gratitude and sincere thank you goes out to Dr. Ittifat Hamzavi for taking time out from his busy schedule and agreeing to share such an insightful talk with us. A sincere thanks to our ever-supporting seniors of the Delhi State Branch for always encouraging us with our endeavors and agreeing to chair the sessions for us today. Our esteemed faculty today, you all were brilliant and we all have benefited immensely from your knowledge sharing. Thank you to each one of you. Thank you, O.P. Gangwani sir and Dr. Vinay Sen for taking time out to assess the posters that were put. We are grateful to you for the same. A big thank you to all the residents of the Delhi State Branch, of all the residents of the Resident Connect Committee of the Delhi State Branch, especially Dr. Anuva Bansal, convener of the RCC Delhi. You've been really great in your active participation in bringing about the social awareness video on vitiligo and taking time out to post such beautiful posters. The judges did say they had a tough time judging them. I would be failing in my duty if I do not thank Dreams Conference once again for their superb technical support in helping us host this event. Thank you, Mr. Jitin Batra. So let's celebrate the beauty within. And with that, good evening to everybody. Thank you.